Check, check. So yes, good afternoon, everybody. So we have seen earlier morning sessions regarding physiological and pacing. So I think we are on the second session of the second day on the International Conference for Cardiovascular Technologists. So to quick start off the second session, I would like to welcome the moderators. Let me welcome Girish Gopinathan and Nagarajan, Bala, Swami. Can we give a big round of applause for all the moderators here? So I could see so many excited faces waiting to actually do the presentation and also to eagerly waiting to watch what the other people's presentations hold. So I hope you'll all have a great time today. So on that note, let me welcome our first speaker of the day, Mr. Harish, regarding New Year advertisements in TRA. Newer advancements in TRA. Yes, can we give him a big round of applause, please? Thank you.
Hi all. Very good evening to everyone. I'm Harish. Very good evening everyone. I'm Harish from Terumo and I'm handling Terumo for Kerala and Karnataka and been with Terumo for last 8+ years. And I would like to thank the organizers for giving me this opportunity to present here. So a bit about Terumo. You all know Terumo. I don't have to explain you what Terumo is. Terumo is a 100-year-old medical device company. You must not have seen many companies who have completed 100 years into medical devices. So this is mainly because Terumo always looks for perfection and the best quality products, and always if they even they have their best quality products, they still try to improve on that to give the best to the patients so that better patient outcomes are ensured and safer procedures are ensured. So our R&D is always towards that this thing, and Japanese people are always looking for perfection in all what they do. Yeah. So in that note, let me take you through two of our great products which helped in improving the patient outcomes and ensuring safer procedures. So the first product is Glide Sheet Slender, which is our new transradial introducer kit. You all know Terumo sheets. So this is our new sheath from Terumo, which we introduced almost 2.5 years before, which many of you must be already using it and many of you must be already knowing about this product. But let me take you through this great product. So the concept of this product is to expand the possibilities of transradial interventions. So so usually you do a transradial intervention usually either with a 6 French sheath or with a 5 French sheath. Usually you don't go mainly many times to 7 French because you have limitations of radial artery. So with this product, TRA can be applied to the patients with a smaller artery, and smaller puncture site helps in minimizing the chance of reduced radial flow, spasms, radial injuries, and delayed radial artery occlusions as well. And another advantage is from ad hoc diagnostic angiogram to ad hoc PCI, you can have a seamless transition with this product. And you have got more and enhanced treatment options available in complex PCIs such as kissing balloon technique. You want to use a larger rotabar, etc. In those kind of cases also, you can do, you have products available in GSS. So this is shortly called as GSS, Glide Sheet Slender. So the product feature is this sheath has got a very thin wall technology that is resulting into 1 French downsize in terms of outer diameter. You all know that sheath is always known for its inner diameter. Nobody talks about outer diameters of the sheath. So because your devices has to go through that, so always people used to talk about inner diameters. So the benefit of reducing outer diameter of this sheath is with a newer product and newer material with a hydrophilic coating. So this ensures smooth insertion and removal and also minimizes vessel damage. You can see like a regular 6 French conventional sheath, and you can see a glide sheath slender. You can see the thin wall technology which ensures like smaller puncture sites. So we have got 5 French, 6 French and 7 French glide sheath slenders available. So you can, like all these comes with a hydrophilic coating. So the insertion and removal is painless, so that the patient will not have that much of pain. And also the transition from the, the dilator to sheath is also so smooth, so that the patient will not feel much pain when inserting the sheath. And another advantage is you have got a 7 French sheath is also available in this. And one bigger benefit of glide sheath slender is, if your sheath is kinked, you have to again change your sheath always whenever you use a regular radial sheath. But with a glide sheath slender, during a procedure, if the sheath is kinked, even then it will accept your guiding catheter. So that is the advantage of this new glide sheath slender. And as I already told you, like seamless transition of ad hoc, TRI, PCI. So you don't have to upsize. Usually when you do a regular angiogram, you go with a 5 French radial sheath. And when you want to do an ad hoc PCI, you have to change the sheath to a 6 French. But that issue is not there with the glide sheath slender. You can directly go with a 6 French GSS or glide sheath slender. So which has got a sheath to artery ratio comparing to a regularly available 5 French radial sheath. This helps you in having a smaller puncture site at the upper, comparable to a 5 French, but giving you the benefit of a 6 French sheath. Then you have a larger sheath available, which is 7 French. Usually, many of the operators have a tension when they want to go for a 7 French. Either they go for a femoral or only they will go with a very large radial arteries. But here, with this 7 French GSS, which is having a sheath to artery ratio comparable to a 6 French of regular sheath, you can easily use a 7 French for your kissing balloon techniques, your rota bursts or larger rota bursts, etc. So with glide sheath slender, which will maximize your procedure outcomes for your diagnostic and interventional procedures without upsizing to a larger sheath, and enhance patient comfort with optimal access for small radial arteries, especially for your lady patients. Even a 6 French will be a little challenging to use on some lady patients, very short patients and all. So those kind of patients, you can easily use a 6 French GSS, which has got a sheath to artery ratio of a regular 5 French sheath. Thank you very much on glide sheath slender, and let me take you through one more product. This is our Ready Focus Baby J guide wire. You all know thermo wires, which is there in the market for close to 40 years now. So even today it's a market leader, and nobody could come out with such a great wire so far. So this Baby J guide wire is a thermo wire only with a very small J tip, which is a 1.5 mm J tip. So this wire will be useful for maybe 20% of your procedures in radial artery, where you see a lot of radial loops and those kind of tortuous anatomies. So in these kind of cases, there is a chance that our regular angled guide wire can go to some small radial, small arteries, and it may cause some kind of vessel traumas and perforations. So that can be taken care with the regular with this Baby J guide wire, which will ensure that it will follow the path of the the artery. So with this small this will actually avoid radial artery side branch selection and also atraumatic navigation through these tortuous anatomies. And we have a 1.5 mm J available, a 2 mm J available, and a 3 mm J available. So 1.5 mm J is recommended for your radial arteries because the radial artery diameter is usually a 2.2 to 2.4 mm, maximum is around 2.6 mm. And for a 3 mm Baby J guide wire, you can use in a femoral case if required. And we have a standard version available with 180 centimeter and 1.5 mm J tip with a flexible tip length of 3 centimeter, and we have a 260 centimeter available, and we have 180 and 300 centimeter available in half stiff version where you need more backup support, more pushability, more one-to-one torque, etc. And also we have a 2 mm J tip and a 3 mm J tip in half stiff and standard versions. Thank you very much for the patient listening. Thank you very much.
Yes, thank you.
Slender car cost, actually when we launched it, it was 3,000 rupees approximately. Yes. Now we have almost reduced it to 50%. Is it? Yes. Since when? Still the MRP is same? The MRP will be same. But since when? End of the day, the MRP will be. How much is it reduced? Pardon? How much is it reduced? To the hospital price we have reduced, almost like 50%. 50%? Okay, good, thank you.
We have 4 French sheet also.
So we have 5, 6 and 7 French available in GSS. We have 4 French sheet in regular radial sheet.
This is very good sheet. Actually, the outer diameter is 5 French, inner diameter is 6 French. That is why it is very good for radial.
No, 4 French slender is not available for the time being. We have, with the 5 French slender sheet, is having the similar sheet to artery ratio of a 4 French sheet. So you can easily use a 5 French sheet wherever you regularly use a 4 French sheet. Yeah. So what I am saying is the sheet to artery ratio of a 5 French GSS or a glide sheet slender is equivalent to, almost equivalent to a 4 French regular sheet. So that wherever you use a 4 French regular sheet, you can always move it to a 5 French GSS. Yeah, it's very thin, and also it has got hydrophilic coating, kink resistance, and even if it is kinked, it will still accept your guiding method. Two colors in that. Yes. So whenever you do it for, one thing is like, Thermo as a company, I can't say that you should do sterilization. But if at all, I know that India's practice, I know. So even if you want to do it, one thing is and another thing is like, even if you want to do a sterilization, unofficially I can say that, please don't record this, but unofficially I can. Yeah, I agree. So for such cases, my only request to you is, especially for GSS kind of products, like, don't use high temperature ETOs. Don't use high temperature ETOs. Please use your cold ETOs so that the product will be intact, the hydrophilic coating will be intact. Yeah. Yeah, that is also okay. Yes. But always there is a risk that any sheath if you reuse, the valve side and all inside, you don't know blood clots or anything is there or not. That is the reason I am saying I will never recommend reusing any sheets.
So, is there any more questions
Any
left?
further questions?
Any further questions for?
They can mark with the permanent marker. Yeah. So even if you want to do an ETO, you can do some marking or something so that this is not getting mixed with your regular sheets.
So the Meridien wire you are telling, no? That is a regular wire or the stick wire?
No. This is a regular ready focus thermo wire with a J tip, very short J tip. We have 035 into 150 J tip. Yeah. So we have a half stiff and regular versions available. Many of the doctors are using it. So, yeah, Baby J guide wire, we don't recommend Baby J guide wire in all your procedures. Baby J guide wires is basically for your tortuous anatomies of radial artery. So if you find a radial artery loop, those kind of cases, if you don't want, and those kind of cases, you don't want to scrape your inside your artery, or if you don't want to have a no radial artery injury and all, these kind of cases, like this will actually follow the track of the loop because of the J tip. You can see this is a J tip and this is angled. So angled can go and scrape the vessel wall. In only in these kind of cases. Only in acute bends and those kind of cases. Yeah.
So for this radial loop, normally when normal wire doesn't work, we're supposed to use that PTC wire. It works.
Yeah, that is also.
Because the diameter changes, more thinner wire. But what about
your support will be very less? No, right?
But it takes the radial loop and then straighten the wire. It straightens the wire. But I don't know about the your
so
baby loop.
Baby J
so diameter is same.
So diameter is 035.
035.
035.
So
Regular 035 wire.
It will cross the radial loop.
Yeah. Yes. It's a nitinol wire.
We use normally we change it to PTC wire because 1/4
So
wire.
you can try this wire, sir, and see how it is.
It's not available to us.
It's no in Baby J we have only 035. Thank you.
Yes, thank you. And to present a memento for Mr. Harish, may I welcome Mr. Girish Gopinath. So once again, can we give a big round of applause for Mr. Harish on the topic of newer advancements in TRA representing Terumo. Thank you so much. And the next speaker, may I welcome Dr. Rao Bhimsen. On the topic advancing the science of flow restoration, representing advanced medical system. Yes, can we give a big round of applause and welcome him onto the stage, please?
Distinguished ICVT 22 conference moderators, my industry colleagues and cardiovascular technologists. I am Bhimsen Rao. On behalf of Advanced MedTech Solutions, I extend a warm welcome to all of you for my presentation on advancing the science of flow restoration. AMS with great visionaries coming from global entrepreneurship and global manufacturing background, along with the great technologist, Dr. Manuel Parante, who has a legacy of almost 40 years of in the design industry for the catheter designs, with many inventions and the patents, who is rather on our advisory board to give us the technology in terms of making in India. With that concept, we started in India manufacturing PTCA balloons and at the same time all interventional cardiology products under one roof. So with this quick preamble, I once again welcome all of you, and then I'll take 2 minutes of a small video to introduce you about our world-class facilities. Rather, I would call it as a state-of-the-art excellence. And looking into the facilities, that you will realize, what is the effort gone into this in terms of delivering the products which are of high quality. Is the audio here? Can play now? I think there's some issue with the audio. It's full. I'll take it to F5. Yeah. Wait.
Okay, video is here.
Yeah. That's okay, no issues. I'll skip.
And it is there. Which side, sir?
Yeah.
Which side, no?
Third one. That's okay. It's okay, I'll just move on to the next slide, no issues.
Let them see now.
Yeah. Just a video without, you're not able to get the audio here. There's some technical glitch. Anyway, let me take you through a few of the slides here. This is the state-of-the-art excellence where we have established the plant. Again, if you look at the facility, it is being designed by Ricardo Bofill, who is a Spanish architect, and then he has also, designed the projects like Barcelona Airport and many football stadiums and so on. So with that kind of the vision in terms of putting up the facilities here, it's being created in about 11 acres of land, and 150,000 square feet is built, and the second phase it is planned for 180,000 square feet, and within that we have almost about 35,000 square feet of clean room facilities, Class C and Class D, and then it meets all the green building principles. So these are the clean rooms with the state-of-the-art, the machineries coming from across the globe. On top of it, with a visual factory concept. The in-house lab facilities complying to all regulations, including 13485 and as well as the CE. These are the areas earmarked for this stent manufacturing and the balloon manufacturing. And we are committed to a professional development in terms of academy, where we have the facilities for simulation centers and as well as the training facilities where we engage the cardiovascular technologies and also the eminent cardiologists in terms of practices. So this is just to give you an idea. We are touching 2 lives every second in terms of our product portfolio, whatever we have right now, both in the wound closure and as well as this interventional cardiology. So we have presence in almost about 161 countries. The small few glimpse of global pictures, few customers. Yeah, as far as the flow restoration is concerned, the science of flow restoration, I was talking about the next generation technology in terms of whatever the design, the cutting design or the design edge that we have, translating into a better clinical outcomes. And of course, this has been taken from Swiss technology, as I already mentioned to you. The Manuel Perante is responsible in terms of giving us the tech transfer, making in India, and again we are supplying back to Europe and the rest of the world. Now, as far as the product portfolio is concerned, we started with dilatation catheters in order to prepare the lesions pre and the post, and then we also have our own stent delivery systems that is used for the coronary stent systems, and apart from that, the entire range of accessories. So these are the coronary stent systems, accessories, and of course it's a AMS proprietary technology and the design. Now, as far as the design edge and differentiators, which I want to highlight in terms of the application support that what we are providing. Here, for the PTCA dilatation catheters, the materials which we have used is L25, that is a nylon, the latest one. And after testing about 248 materials that we have chosen this L25. And because of that, the thinnest balloon material that what we could produce is about 0.008 compared to any other materials, which is of 0.3 or sometimes it is even 0.1. But then here we have 0.008, which is the thinnest balloon material. Despite that, it can take up the pressures. It can take up the pressures up to 18 bars and 20 bars. And the actual test, the burst pressure is up to 25 or 26 bars it can take up. And if you look at the design, generally, there are 2 issues which we come across in any of the balloons. One is the dog bone effect, and another one is the edge dissections. So these 2 are not there in our technology what we have used, and because of this 42-degree cone angle, the tapered balloon design that what we have, even the edge dissections are being avoided. Now, just getting into the design aspects of it. Now we have the lowest entry profile 0.016 and the crossing profile. Even if you look at the smallest 1.25 to 4.5 mm balloons, the smallest, the crossing profile also 0.50 to 0.740, and followed by the tapered balloon with 42-degree cone, avoiding the edge dissections. At the same time, if you look at the shaft, again it's a kink resistant shaft with the greatest pushability, and the thinnest balloon material which I mentioned 0.008 mm. Along with that, it is being coated with a hydrophilic coating right from the RX port till the tip. So the gliding across any of the tortuous lesions will be quite easier. And of course, another feature which I want to highlight is it has got the fastest deflation time, 0.3 or rather 3 seconds to 10 seconds. Generally it is about 20 seconds, but then in our case it is being reduced. So when you have a fastest deflation time, that means you have also have a fastest inflation time also. And the size matrix, like as I mentioned to you, 1.25, where we have it for 0.560 crossing profile and then 0.740 for the 4 balloons. So with this low crossing profile, again getting entry into any of the tartarus lesions will be quite easier. So you can look at this deflation time. So it's just about 3 to 10 seconds. And the differentiators, which I want to highlight the differentiators here, that compared to any other leading brand that you can take up, A, B and C, we have the lowest entry profile, and then followed by, I was mentioning about the working range. Working range is semi-compliance balloons we have from 6 to 18, and then non-compliance we have from 8 to 20 as far as the RVP is concerned. And then all these features, all these specs that which we are, we have the differentiator are again not just the claims, but then they have been got tested in Endolab Germany, where against these A, B and C, so we have the trackability, and we also have this pushability testing in terms of having highest force transmission of 0.19 against again the brand A, B and C. So finally it's translating into the specs what I have listed here. You can look at the average deflation time, 3 to 10 seconds. And the compliance chart I mentioned again, 6 to 18 and 8 to 20. The huge size matrix, 1.25, 10, and then it starts up to 4, 4.5, and in the non-compliance we have up to 1.5 to 5 mm. Now with this experience of launching this pre-dilatation catheters, both semi-compliance and non-compliance, then the stent delivery system that what we have is again our own same platform that we have designed and then we have been manufacturing, and that is being used. Most of the other manufacturers probably they must be importing the stent delivery catheter, as it is playing a major role in terms of the angioplasty procedure. So we have two brands here, and followed by the three important components which we look at any of the stents is your stent delivery catheter and the stent, and then of course the drug and the technology for. So we have, as far as the stent is concerned, we have addressed in terms of small vessels, mid vessels and large vessels with the 6, 8 and 10 cells, and with the lowest entry profile and the final crimping profile getting 0.95 to 1, and then rest of the features are like 0 foreshortening, the recoil less than 5%, and the metal to artery ratio less than 18%, with the lowest strut thickness of 65 microns. So with this, the design that which we have adopted is again the hybrid design, which also supports in terms of your the side branch axis. This is about the stent delivery catheter. And another important thing is that we have an ablumous coating. So it's the latest one that everyone knows about the advantages of this, that we have used the ablumous coating with low dosage and then the other benefits that what we are getting in this compared to a typical spray coating that is being used in most of the other stent systems. And then the sirolimus drug. And of course with the biodegradable polymer matrix with the poly D and then L-lactide. So converting into a final spec sheet that which I'm going to show it here. It's again, if you can look at the key features like lowest entry profile 0.016. So it will help in terms of crossing all kind of lesions. And the other specifications which are, 0 foreshortening and then the wide size matrix with the ablumous coating. So these are the key features which, I already mentioned in this. So with this, what I want to convey a message that the first and foremost thing is that we have been manufacturing in India, and not only for Indian market but to supply to the rest of the market worldwide. Then secondly is that the differentiators that we have created in terms of surpassing all the specs compared to any other leading brands A, B and C, and then accordingly the best of the clinical outcomes that what we have received right now across all India with the clinicians' feedbacks. We have got the best of the feedbacks in terms of its clinical performance. So that is possible. It is the kind of technology that we have adopted, the kind of process that we have adopted in terms of the manufacturing and the facilities that is being created into this. And with this, we are moving ahead in terms of introducing few more products, and which could be in the pipeline. So very soon we will have even the heart valves and the TAVI and many other product range into the AMS brand. Thank you very much for your patience hearing.
Yes, thank you so much, Dr. Rao. So yes.
Pardon? Pardon? Marker is 6 mm. It's on the shaft. 6 mm is the sharp marker on the shaft.
Single marker, single marker and
Two markers. Proximal and distal.
your size starts 2 only.
2.25.
No, diameter 2.25.
2.25. 1.25 is for semi-compliance and 1.5 for non-compliance. Yes. Yeah, it increases from 0.540 to 0.740. Yes. Threefold. It's a threefold wrapping and rewrapping.
Our suggestion, usually our balloon damage looks like a little unconventional. Maybe balloon, something looks like not.
No, it's not unconventional. Basically, it's Advanced MedTech Solutions is our company. So we have just aligned. If you see our all products, even in the wound closure or if it is in the IC, it starts with Adva. We have a stand with Adva Pro. We have a balloon with Adva Glide. We have Everolimus coming up with Adva Ace. So. Yeah, we have tested. Yes. Yes. Yeah, it is tested on that basis only. And all the test reports that we have got it generated from Endolab Germany, each and every specs against ABC, the brands.
So yes, is there any questions from the moderators? From the audience? Yes, okay. So, to give a memento to Dr. Rao Bishma, let me welcome Nagarajan. Yes, so can we once again give a big round of applause for Dr. Rao Bhimasenan on the topic of advancing the science of flow restoration, representing advanced medical system. Thank you. And as the next speaker, we have Millie from Relicis Medical Devices on the topic of newer horizons in the management of tricupsids regurgitation trick value solutions. Can we give her a big round of applause and welcome her? Yes. On to you.
A very good afternoon to the August gathering, and on the onset I would really like to extend my warm thanks to the entire committee. It is a wonderful conference, very valid learning opportunity to one and all. जिस excitement के साथ हमने technologists को आज दिन भर involve होते देखा है, it is just replicating like any other medical conference. So I think we should start with a big applause to all of you. Thank you very much, the organizing committee. And today I am here on behalf of Relicis Medical Devices, and I will take you through our very revolutionary product, which is the trick valve. As the name suggests, it's a very tricky and important valve for tricuspid regurgitation. But at the onset, I will just take a few seconds to brief myself and my organization exactly. I am Millie. I am the product specialist. I represent Relicis Medical Devices. This is actually a screenshot of our facility, which is a wonderful facility in Hyderabad. And let me begin with welcoming all of you. जब भी आप लोगों को लगे कि एक दिन का break लेना है, please be a part of our facility. We will welcome you with open hands and come and have a visit of our facility. It's a beautiful ISO certified with the best standards facility. So there's a screenshot of the beautiful venue what you have selected. बहुत ही सुंदर जगह है. Ours is again a very completely integrated facility. Integrated facilities are those जो अपना entire procedure of manufacturing अपने ही organization में करते हैं. So starting from the scratch of the process to manufacturing the entire product, everything is manufactured within the facility. हम बाहर से कोई भी चीज़ procure नहीं करते हैं. We are also an ISO 13485, the highest level of ISO certification, with a completely 160,000 square feet class 10K clean room facility. The facility is 13485, as I said, and we are recognized by the DSIR. So this importantly tells us कि हमारे पास में हमारा in-house research department है. We have a very strong R&D department जो हमारे प्रोडक्ट्स को टाइम टू टाइम अपडेट करने के लिए और नए प्रोडक्ट्स लेकर आने के लिए भी बहुत ज़्यादा हेल्पफुल है. सो वी आर अ कंप्लीट रिसर्च एंड मैन्युफैक्चरिंग फैसिलिटी. With the virtue of technology platforms, we have developed platforms in metallurgy, polymer and drug coating segments, and the company is capable of developing variety of devices in cardiac and peripheral segments. So right now we have a cardiac portfolio. Very soon we are also coming with the peripheral portfolio. We have enough capacity to be cutting stents for Indian demands as well as international demands. हमारे बहुत सारे customers हमसे international waters से हमसे produce करवा करके brand करके बेचते हैं. So we are into OEM in domestic as well as international markets, and we are one of the largest manufacturers of stents across the globe. So on behalf of Relicis, oops, I'm sorry. ये हमारे products की range है. We have stents which are in the sirolimus and everolimus category. Premier and Pristine. इसके अलावा हमारे पास में Ensure and Eliminator है. We have Cobalt stent, which is a bare metal stent. We have Jade SC and NC, which are our balloons. Anant diagnostic catheter है. Amber angiographic catheters है. Access guide हमारा guide extension catheter है. Ensure and Eliminator जैसे मैंने आपको बताया ये CE mark products हैं हमारे, CE mark stents हैं हमारे. And then we have the range of valves, which starts with the trick valve. We have recently launched marker pigtail. The range of products that we have, just for a glance, we have an entire basket of accessories also for your use. ये हमारे कुछ products in pipeline हैं जिसमें कि wedge pressure catheter है, hemodialysis catheter है. We will be coming with micro catheters, steerable micro catheter, expandable sheath, covered stents, and a few renal care products also. Transcatheter heart valves में what we have right now in the market is our trick valve, the tricuspid valve. We will be very shortly launching a TAVR valve by the name of Vienna aortic valve. We will be having our Vienna mitral valve as well as Vienna pulmonary valve. Both are self-expandable transcatheter valves. We will also be bringing transcatheter entovental to you. So this will complete our range of valves, transcatheter valves from Relicis. This is the revolutionary trick valve. And what exactly my topic was to discuss the newer horizon in treatment of tricuspid regurgitation, which is through this trick valve. Let's go through these few slides where we will understand. You all agree that tricuspid regurgitation has a very, it is a very significant disease, which in US alone 1.6 million people, more than 1.6 million are actually affected. They all have very, very high mortality rates. But we have very little to do when it comes to giving them some long-term treatment. Multiple transcatheter devices also were developed, but very little could be done actually to address the issue. So when a tricuspid annulus is very severely dilated, or there are prior pacemaker leads, which are more than or almost 11% of the patients who walk in with TR, is Keval implantation a good option? So this is for us to see and accept in the coming time. This slide just talks about how the prognosis of tricuspid regurgitation in patients takes place. So basically all these patients come with very, very severe condition, and overall survival is very, very compromised. They are patients suffering with chronic heart failure, LV dysfunction. There are added comorbid conditions that these patients are facing. So if they have left-sided disease as well as there is an AF or an HF, then the outcome of treatment to such patient definitely worsens, and we have very little left to actually give offer to them. So in such scenarios, for our doctors, for our cardiologists, these patients are a very, very complex group, and what they try to actually do is look at the demographic features of these patients, club the cardiac pathological remodeling, and see whether is there some option possible for them to offer to these patients. So, such patients who are NIHA functional class very compromised, or probably they are suffering from added comorbidities. So here as we see that patients who are suffering from mild TR might come to you and very soon progress into a stage where they are going into severe situations. The heart failure and all these issues start enhancing. So if we are not able to give justice or give them some right therapy at the right time, they may very soon lead to a point from where there is very less to offer and there is hardly anything that the doctors can actually give them. So beyond this point of no return, if much before this, we try to offer some kind of therapy to these patients, probably we can give a significant improvement, and those patients, as we have seen, they do not regress to the worsened stage, but they definitely do not need a surgery and they live a very, very healthy life. So what exactly can be offered before they turn from mild to moderate or to severe? These were few therapies which are there in the market and which the doctors try to offer to these patients. Either there could be a direct suture annuloplasty, or there could be a ring annuloplasty, or probably coaptation devices can be used. There are some who directly address the native valve, the native tricuspid valve. And in these options, none of them have actually shown any longevity or probably a in this image, the SVC and IVC have two valves. So the SVC valve and the IVC valves are the trick valve, the pair of valves that are implanted in the SVC and IVC of the patients. Trick valve, transcatheter bicaval valves are two self-expanding biological. Intended for patients with very extreme risk or who are inoperable, who have been denounced by the surgeons to be taken up for any kind of surgeries. Prostheses are implanted percutaneously into the inferior and the superior vena cava and without disturbing the native tricuspid valve. So we do not address the native valve, but basically on the SVC and the IVC level, the pair of valves are deployed. This is how the two valves look. They are basically nitinol frame valves. The bulbous valve is the SVC valve. The tubular valve is the IVC valve. And as we can appreciate, the bulbous valve, both the valves are nitinol frame, so they are self-expanding valves. They show a skirt. SVC shows a longer skirt. The IVC will show a shorter skirt, basically to save the hepatic veins. And here so that we can avoid the paravalvular leak. The bovine pericardium in SVC is at the bottom. Bovine pericardium at the IVC is at the top. I mean, because of the position they will be placed. These are the 2 points where we will be having the valve, the pericardium of the valve. Now this is a very, very innovative technology which PNF or Relisys Medical Devices have actually researched into. We have a dry tissue technology, and with the benefit of this dry tissue technology, we are able to dehydrate the tissue valve. The bovine pericardium which is loaded on the valve, that tissue pericardium is dehydrated, and in that state it is loaded on, it is crimped on the native valve, yes, due to which we are then mechanically able to crimp this valve into the delivery system and present it to you in your labs without any storage of the valve in the glutaraldehyde or any kind of preservative solutions. So this basically gives us the freedom to keep the valve absolutely, yes, temperature conditions nahi chahiye, glutaraldehydes nahi chahiye, koi person nahi chahiye, yes. On a normal temperature, just the delivery catheter and the valve crimped on it. What exactly is the dry tissue technology? It's basically a dehydrated pericardial leaflet. It is, yeah, you will directly get the valve loaded. So probably you can call that it is like a mechanical valve. But this is a transcatheter valve, one thing. And the bovine tissue, you have to rehydrate at the time of the process. Because eventually it is a dry tissue. So the tissue is still there, which needs to be salinated, which needs to be rehydrated just before the procedure and then implanted into the patient. This dehydration basically takes away the water content, so it avoids the calcium deposition on the valve. Second thing, very important thing, it reduces the thickness of the valve. A thin valve is more tensile, a thin pericardium is more tensile. The tensile strength, if it increases, then the number of opening and closing cycles of a valve, that is the life of the valve, that increases significantly. This is here one major benefit we have of the dry tissue valve. Since the life of the valve increases because of its thin nature, the opening closing number of cycles of the valve increases, and our valve life is much longer as compared to the other valves which are in the rehydrated stage. It also improves the integrity of the collagen. So as long as the collagen is in its own nature, in its own form, the longer the life, the valve is again having a longer, if the collagen is sustaining for a longer time, the valve is having a longer life. So we can see in these images that the calcium deposition is also definitely lesser because earlier it was in a rehydrated state. There were no calcium deposits when the pericardium was loaded on the valve. Only after it is rehydrated and positioned in the patient body do the calcium deposition start. And even at that time, since they are also anti-calcification treatment loaded, the calcification deposit takes a lot of time. So it also reduces the calcium deposits on the tissue valve. this basically shows the concept of what trick valve is. So it avoids backflow. Since we have the two valves at the SVC IVC position, presence of a trick valve will avoid the backflow. It will definitely reduce congestion and will promote a positive remodeling of the right heart. So these will bring down the patient, the symptoms of the patient, the quality of life of the patient improves, mortality benefits. Should I go to the next one? There is a CT angiogram protocol which we request basically so that we do not get into the problem of valve mitigation. We do the right sizing and thing. A CT angiogram protocol is followed and the right sizing of the product is given to you. It avoids the risk of PVL as well as mitigation of the valve, migration of the valve. These are the 7 sizes we have with us. SVCs are available in 3 sizes, 25, 29 and 33, whereas IVCs are available in 31, 35, 41 and 45 millimeters. And every valve has a independent diameter and length. So all of them are dedicated valves as per the anatomy and sizing of the individual patient. But yes, 7 fixed sizes are available. They are not tailor-made to every patient. There are some fixed sizes that are available. SVC measurements are basically taken on 7 landmark parameters. This is basically to help us decide what size exactly should we offer to the patient basis on his CT venogram that is provided to us. So we need the diameter of, since the SVC valve hangs at the brachiocephalic confluence, so basically we start with the diameter of the brachiocephalic confluence. Then we start taking the diameter of SVC at the level of top of pulmonary artery, diameter of the SVC at the level of middle of pulmonary artery and bottom of pulmonary artery. This basically helps us to adjust the bulbous portion of the SVC valve, and then the diameter of SVC at the bottom of pulmonary artery, which is exactly the size of the valve, and the diameter of SVC right atrium junction. These length between brachiocephalic confluence and the pulmonary, as well as the entire length, all these totally help us to decide the size of the SVC valve. So here we can confidently say that since we have dedicated valve designs, self-expandable dry tissue technology in every valve, crown anchoring at the brachiocephalic confluence and belly providing anchorage at the SVC level, there is a high skirt to prevent the PVL. Every valve is individual to every patient. Similarly, the IVC measurements, what we take are 5 in number. These are basically, again, IVC RA transition diameter to know the size of the valve we should provide. IVC at the top of hepatic veins, just below the IVC diameter, just below the hepatic veins, so that we can give you the height of the skirt and it should not block the hepatic veins. IVC 5 millimeters below the IVC RA transition, and IVC transition to the top of hepatic vein total length, so that we can give you the total length of the valve. So all the IVC valves again have a dedicated valve design, self-expandable dry tissue technology, minimal protrusion into the RA, that is how the sizing is given, low skirt to prevent the PVL or blockage of the hepatic vein inflow, and opal cell design, so that again if we need to do anything at the hepatic vein section, we do not face any problems. So the cell design is also a little different than the SVC valve. So trick valve, bicaval valves are implanted, as mentioned, they are implanted in the SVC and IVC. Delivery of these valves is done using a 28 French flexible catheter and at the transvenous route. It is an alternative to open heart surgery, requiring only 30 minutes to perform, and it yields an improvement that is immediate, reproducible and persistent. And the entire system consists of a transcatheter bicaval valve for SVC, transcatheter bicaval valve for IVC, and the delivery system. So 2 valves and 2 dedicated delivery systems. Just a glimpse of additional equipments that you require. There are almost everything available in the cath lab. And these are a few criteria of patient selection. Clinically, we try to capture mostly severe to extreme patients, NIHA class 3 or class 4, patients with ejection fraction more than 40%, those who can at least walk 60 meters in the 6-minute walk test, and a life expectancy of minimum 12 months is necessary. We also take care that left-sided valvular issues should not be there in such patients. Severe renal failure patients or liver cirrhosis patients are a total no. Simultaneously, on the hemodynamic side, we need to see the V wave in the IVC and SVC, which should be more than or at least 25 mmHg over mercury. Right heart failure measured over TAPC, which should be more than 14 mm over Hg, and systolic pulmonary pressures at least not more than 65 millimeters over Hg. These are a few these are a few implants under angiographic view. You can see different stages of implantation of tric valve in these figures. So most of the alternative therapies that are available are done directly into the native valve, and whereas when it comes to the tric valve bicaval therapy, this method is basically to address the tricuspid regurgitation and caval reflux without facing high risk and challenges of orthotopic valve migration, because we are not addressing the native valve, we are doing an SVC IVC procedure. So the question that stands in front of us is the bicaval tric valve implantation a solution on the horizon, and can we look at better results by giving this bicaval therapy instead of native valve therapy? These are a few preliminary data that are available with us. So we did some special access program, early feasibility trial, a CE mark trial. A small number of patients were evaluated in different centers in Lithuania, Spain, Turkey, Brazil, Austria. We had 100% procedural success in these cases. This data is basically pre-COVID time data. We could not really have a complete follow-up that time because of some restrictions. 38 patients were implanted, but only 16 could complete their follow-up basically. And when we come to see the improvements over the 6 months of such patients, most of the patients we included were NIHA class 3, class 4 patients. But as you would see, many of them improved and all of them went into NIHA class 3 or class 2. Few also improved to NIHA class 1 also. So the functional class improvement was very good. This is the improvement patients faced in their 6-minute walk test and the quality of life. Significant improvement in 6-minute walk test. QALY also improved from 36 to 66. Patient weight started reducing slowly over 6 months. This is a very important slide for us, as well as it creates a lot of news among the doctors. This is the RA-RV volume pre and post implant of the patient. So we see that pre-procedural to post-procedural RA volume improved, reduced by 38%, and the RV volume also reduced by 49+%. So definitely the claim of right heart remodeling has set in, and the patients are, that is the one more reason the patients are showing significant benefit in 6-month outcomes only. This is the improvement in the hemodynamics of the patient pre and post CAVI. The IVC waves have reduced. Okay. So these are the basically the improvements patients faced at the TRICA study also. A few patients that our doctors did with who were extremely high risk patients, and they benefited. So we had patients from Dr. Nihar Mehta, Dr. Harish Mehta, Dr. Puneet Verma. And the device and its advantages, basically it is implanted percutaneously and it is responsible. There is not really much need to be repositioned, but still if it needs be, then it can be repositioned, retrievable up to 80%. It's a pre-mounted delivery system. The hassles are very less. No device related mortalities were actually seen. So in conclusion, we can say that it definitely For us, we can claim that it is a very promising and less invasive concept. For you, there is a lot of ease in doing the procedure. So successful, uneventful experiences give us the confidence, and we request that you all also show your trust and help us build this therapy, help us move this therapy much more, and try to screen some patients for us. So trick valve is associated with a very good improvement over 6-month follow-up. Look forward to more guidance and support from you. Thank you very much. Yes, sir, please.
18 French to 20%. As you told that we have to use 28 French
Yes,
at the time.
so we are going to the IVC as well as the SVC.
Okay.
Right. And the device sizes of SVC are definitely bigger. So the catheter which is used is a standard size catheter.
Okay.
No, he's saying, you said cavi or tavi? In tavi.
They are asking you, we are using 28 hours, 21 French, and now you are using.
Sir, this is through the vein. Yeah, this is through the venous system. So this has to be a bigger size, and the size of the valves are much bigger than the TAVI valves.
How many you have implanted till now?
Sir, in India we have done 50 plus cases. Globally we are almost 700 cases now. And very recently we have also joined hands with Cleveland Clinic so that we can apply for a US FDA approval also. So we will soon get bigger numbers from US also. Yes. Almost 700 patients. Sir, second.
Actually, you are telling that you told that coronary disease patients you are not taking.
No, sir, left-sided issues should be resolved first.
Okay. After procedure.
This is RV.
After implantation.
Sorry.
After implantation of your SBC and IVC
Ji.
devices.
Ji.
In the future, patient needs bypass surgery. They are going on pump.
Cannulation is a challenge for us.
Problem for them?
Definitely.
Yes, sir. It is a problem.
It's a problem.
Sir, cannulation is a challenge. As of now,
There are doctors who do it without.
sir, as of now, no, not like that. As of now, from the 50 plus patients we have done in India, starting from 2018. 2018 was our first patient. 2019 was our second patient. None of these patients have come back for another advanced coronary disease enhancement. Yes. So as of now, we have not faced this situation that we needed to cannulate the, yes. Yeah. So probably either we don't know or the patient has not advanced further, has not gone worse. Either he is maintaining the right heart as well as because of it, the added left heart issues improved and the patient did not need any further address of the left heart or whatever. Thank you. Thank you so
Yes,
much.
thank you. To present the memento, I would like to welcome Mr. Bala. Yes, so once again, can we give a big round of applause for Millie, representing Relisys Medical Devices. Thank you so much. And the next is Naseem Shah Nazrullah on the topic of innovative Indian medtech company representing Merrill Life Sciences. Can we welcome him with a big round of applause, please?
A very good afternoon to one and all. It gives me immense pleasure and privilege to share the dais here on the International Cardiovascular Technician Conference. So beforehand, I would like to share my thanks and gratitude to the committee for giving an opportunity and of course for pulling out such an informative and insightful conference. So I would like to represent Merrill Life Sciences here. So before going into my topic, I would like to give a small introduction about myself and my company. So myself, Naseem Shah Nasrullah, I look after the structural heart portfolios as a therapy specialist heading the South Indian market. Here we have Meridien Life Sciences, an Indian company, innovative company for the legacy for the last 12 years, which is situated in Vapi, near to Mumbai. And we have a business in more than 140 plus countries with more than 10 plus subsidiaries in all the European and American markets, of course. And coming to the corporate DNA, we have 4 different verticals with large portfolios of 140 plus products and technologies, and of which most of them are being manufactured in India itself. And we have cardiovascular, orthopedic, endosurgery, and diagnostics separately, and of which one of the robotic surgery, the key, one of the innovative thing has been added recently to the basket. And of this 140 technologies, I would like to showcase some interesting on cardiovascular field. Here we have a Meridien Academy, which is a dedicated academy for training the physicians, technicians, of cardiologists, of course, and we used to invite most of the technicians, doctors, and many of them to visit our plant, which is one of the most beautiful plant, which is done by all the ISO standards. And in 2019, we had conducted a conference where 250 surgeons from more than 20 countries has visited our plant. So the first I would like to talk about MyWell, our key product on TAVI, which has changed the face of TAVI in India, and of course. So this is built on a balloon expandable platform on a nickel cobalt alloy frame, and it has open and closed cells. The inflow zone comprises of closed cells intuitively for the high radial strength, and the outflow zone has a larger hexagonal cell which are kept intuitively open for preserving the coronary blood flow. The design is composed of hybrid honeycomb cell design, which is 53% of it is open cells and 47% it is made up of closed cells. The closed cells, in the sense, the inflow zone is covered by a polyethylene terephthalate to prevent any kind of paravalvular leaks. So as we all know, the aortic annulus is a kind of a eccentric shape. It's not a pure circular shape. So if we put a pure circular MyWell into that, there can be chances of microchannels which can lead to PVL. So this external PVT skirtings, they plug onto those microchannels and reduces the paravalvular leaks. So which has demonstrated in our recent studies conducted by Dr. Patrick Seris from Ireland. And to come forward with another USP of MyWell is the sizing. So conventionally, when the balloon expandable TAVI was launched, there were only conventional sizes of 20, 23, 26, and 29. So which created many such contradictions, like risk of PVL, pacemaker, and many more. And so that's why we thought to introduce the intermediate sizes along with conventional, which are 21.5, 24.5, and 27.5. And of course, and 30.5 and 32, which are the XL sizes, has been launched recently. And Meridien is the only one company which is having the XL sizes which can cover an annulus up to 35 mm. And one point I would like to pitch in here is that of the 8,000 plus cases we had done globally, 45% of the cases has been done using intermediate sizes. So these are all the size metrics of MyWell starting from 20 to 29. One of the interesting key point I would like to highlight is that all the sizes of MyWell can be compatible to the same system of 14 French Python sheet. And these are all the large sizes, 30.5 and 32. And coming on to the accessories of MyWell, the hardware, the first one will be the Navigate delivery system. So you can clearly appreciate that the valve is crimped on a balloon. Of course, this is a balloon expand technology. It has to be crimped on top of a balloon. So here we have three markers, the distal, mid, and proximal marker, and 2 stoppers in between. So in between these 2 stoppers, we have to crimp our valve where we have a crimping zone. So just because it's a shallow zone, you will not be able to, there will not be any kind of a migration once you are taking it through the tortuous anatomy in through the vessels. So direct crimping on table will reduces one extra step of extra jugularity which you are doing inside the abdominal aorta with the previous generation balloon expandable devices. So this is much more user friendly and simpler version. And this navigate delivery system, it's a volume based inflation, which means that for example, if you're taking for say a 23 myval, you have to select the 23 navigator, which will correlate with the nominal of 18 ml. So with respect to that, you will be able to undersize or oversize the valve. On the proximal part of the navigator system, we will be having this flexion shaft, which will be able to take a turn of 270 degrees. This is quite more helpful, with severely calcified aortic arch, or in case of horizontal aorta, which will reduce any kind of a debris formation and, of course, the risk of stroke. And this one is a 14 French Python sheath. As the name suggests, the Python sheath will expand and collapses back to its normal state when the crimped valve has been passed through. The usable length of the system is 30 centimeter with the arrow marker tip, which will reach till the anal artery. Because of the arrow marker, you will be able to easily identify where the sheath has been. And it comes with two dilators of 14 and 18 French and two loaders, of course. And this is the video of a loader. This is the protocol how the myval has been loaded into the Python sheath, and you can clearly appreciate how the sheath expands and collapses back to its normal state. And another USP of Python sheath which I'd like to highlight is the retrievability. The valve can be fully retrieved back to the table in case if you are doing a mitral valve in valve case with the myval, or in case if you have a low purchase in LV, if you lose the wire in LV. In those scenarios, you will be able to retrieve the valve completely back to the table, recrimp it, and you reuse the same valve again. And this one is a mammoth balloon which we are using for the pre-dilatation purpose. These are all the sizes available. Again, this is a volume-based inflation system. So initially for the first generation TAVR, it was something like 1:1 pre-dilatation, or pre-dilatation was mandatory for all the cases. Whereas now we are following a strategy where pre-dilatation is not mandatorily for all the aortic stenosis cases. Just because of the myval is very easy to pass through the stenotic valve, the pre-dilatation is restricted to certain cases like severely calcified aortic valve, or a bicuspid valve with large leaflets, where we have to check the coronary occlusion test. So coronary occlusion test is basically done in two conditions. One, in a native tricuspid valve with low coronary heights. So for an ideal TAVR, at least you should be having 10 mm as a threshold of coronary height, so that it will not block the native coronary ostial flow. So if you are not having that, you will be doing a pre-dilatation test. And secondly, if you are having a bicuspid valve with large leaflets, because bicuspid valve is always an eccentric anatomy, so you will not be able to predict how the leaflets will behave. And third one is a native tricuspid anatomy with severe calcification. So in those three scenarios, we are now only doing the balloon dilatation, and rest every case we are going direct. And this is a crimping tool which we will be crimping the myval directly on the table. So patient CT was something around 26.7 as the annual diameter, and these are all the sizes mentioned, like 26, 27.5, 29. So in the first generation scenario, either you have to go with the 26 valve, or you have to go with the 29 valve, which are 5% undersized, and the second one is 17% oversized respectively. So in both the scenarios, either you have to oversize the valve or undersize the valve, which can cause some risk like a paravalvular leak, annular rupture, or severe pacemaker risk. So if you consider 27.5 for this case, it will be like 5.8% oversized. So we always follow a thumb rule in TAVI. For a balloon expandable valve, 10 to 15% is the ideal oversizing for a native valve, and for a bicuspid valve, it changes from 5 to 10% or even 0 to 5%. So in those scenarios, 5.8% for this kind of an anatomy will be perfectly alright, where you don't want to oversize or you don't want to aggressively size the valve to create any kind of a PVL or kind of a, which will end in annular rupture. So we think of an idea of preserving the geometry and respecting the anatomy as well. So this slide explains the precision placement of my valve. So here it's a cross section, the open view of my valve. Here we can clearly appreciate 3 layers of hexagons. The 2 layers of smaller hexagon and 1 large pair of single hexagon. And so once these my valve is crimped on top of a balloon, if you can appreciate this V-shaped hinges, we call those hinges, they come close to each other and they actually nest to each other and they form this dark band. And this eye connectors in between, they form a light band. So across the fluoroscopy, you will be able to appreciate this dark light pattern like a zebra crossing on fluoroscopy, and this can be very much used for the precision placement of the valve. So this is a CT reconstruction of the aortic root, and this 3 nadir points has been marked with respect to the 3 lines, NCC, red with RCC, so red with LCC and green with RCC. So, and the line depicts there is an annular plane. So we all know that there is nothing like an annular plane as of such. We obtain an annular plane by joining all the 3 nadir points into a straight line. So coming to the USP of my valve, so once you align all the 3 points of nadir, and then we will be able to precisely place 70-30 deployment. For example, if you are planning for a native tricuspid valve, 20% of the valve will be infraannular and the rest 80% will be supraannular. In this scenario, you can take a help of this dark and light band. You can place the annulus exactly at the middle of the second dark band and you can go for a direct deployment. You don't want to change it or maneuver in any form. You will place it like this. You will go under rapid pacing. The funda is to bring down the pressures below 60 mm Hg, and then you will go for a rapid deployment and you will be achieving an 80-20 position, whereas 80% will be in the aortic root, 20% in the LV. In this case, you are not flossing too much into the LV, you are not creating any kind of a permanent pacemaker issue, and we are good with our PVL results also. So this is how the valve looks like in a real valve scenario. You will be able to see the 3 markers, mid, proximal and distal, and the zebra crossing pattern as well. We always use a pigtail in the non-coronary cusp as a landmark. So till the pigtail will be the first thing which is going in, and pigtail will be the last thing which is coming out after a TAVI. So we are okay with the position. It is under rapid deployment. We have a safari wire in place, and then we'll go with inflation. If we are okay with the position, no maneuvering, we'll go with the rapid inflation. We'll lock the position, and you can see how the valve foreshortens. Like 30% was initially kept in LV. Now it has been reduced to 20%. So this is the final result. You'll be able to see. So the leaflets exactly takes place from the 80-20 position. So that's why we always encourage to have an 80-20 position at the final end, so that we are not, deep throating the valve, and of course the fluid dynamics will be on the same plane. So now coming on to the bioresorbable scaffolds. So by the time when Merrill thought about to launch a bioresorbable scaffold, we always had a history of first generation bioresorbable scaffold, which was called back up, unfortunately. So we thought to link what we actually call the bridging the technology gap between a normal drug-eluting stent and of course with the bioresorbable scaffold. So comparing Meris 100, the Merrill resorbable scaffold of 100 micron thickness with a resolute integrity versus the previous generation Absorb. The one thing which I would like to highlight here is that the strut thickness. 91 microns was the strut thickness for resolute, whereas 150 was for Absorb. We thought to create it much more similar to that of a drug-eluting stent. We came up with 100 microns. And the crossing profile, it was 1.4 millimeter. We came with 1.2 millimeter. So there were certain issues with the first generation, which is the tracking, the positioning and deliverability pushing through. So the storage of the system. So there were certain challenges. So we thought to address all these issues. And this is a Meris 100. It is a hybrid design of open and closed cells, which is made up on the platform of PLLA, polylactic acid. So definitely one question or one thought which comes to the mind thinking about a bioresorbable scaffold of 100 microns is that will a bioresorbable scaffold of 100 microns will be able to withstand the radial strength? So for that we have an answer that we have came up with an extra amount of material. So the PLLA which we are taking in, it is almost like double of what Absorber has took in the first generation. So it's almost like 300 kilodaltons. So with that kind of a configuration, we will be able to withstand the radial strength. And the second concern we would like to address is the tracking of the scaffold. Whereas Absorber was having only 2 markers, we are incorporated with 3 markers in either proximal and distal ends. So for example, a circle has been divided into, if we cut into 3 pieces, it will be 120 degrees apart. So in all the 3 120 degrees, we had kept 2 markers, which is a couplet of markers. So in any view, you are going, for example, say caudal or spider view, you will be able to see at least 2 markers in distal and proximal end. So this kind of a visualization will be quite helpful for you to precisely place our stent. And these are all the size matrices available. And it has a very low balloon overhang. And this one is a very quite interesting OCT image of comparison of Absorb and Meris, where you will be able to see and appreciate how much is the strut thickness comparatively with respect to Meris and Absorb. Yeah. So this is a radial strength comparison with respect to our own stent Biomime, which is of 65 micron strut thickness. It was 1.1 bar, whereas we have our Meris as 1.2 bar. And coming into the RO markers of Meris 100, this slide will be quite more helpful for you to understand or to position if you require a tip-to-tip deployment, or you have to overlap 2 Meris together. So the distance from the scaffold RO marker edge to the balloon RO marker edge is 1.3 mm. So this can be utilized for a overlapping stent. So for example, if you had deployed a stent at the distal end, and then if you want to go with another tip-to-tip overlap, this is the ideal strategy. You have to overlap the proximal marker versus the distal marker of the undeployed stent. So this will be the final result. The extra 0.1 mm balloon overhang will be the only area which is left forward. So the Meris 100 comes with a package of pre-dilatation and post-dilation balloon, a quarter size or a quarter size balloon plus a half size balloon for post-dilation. So we call this as a tip-to-tip deployment or a kind of hugging method deployment. And then taking you through the bifurcation lesion, we have a dedicated stent for treating branch. So we call this as Biomime branch. So this is a unique branch which have with a stepper balloon system, and the sizes are available here. This system will simplifies the procedures of Kulot technique. And this is a very dedicated system for branch itself, and it comes with 4 markers: the proximal, the carina marker, the side branch marker, and the distal arrow marker. So you have to make sure that you are following the side branch oxtail markers, because that's where the portion, the stent portion is starting. And rest, we have the flexi connectors and the main branch anchoring segment. So these are the steps to deploy. Of course, we all know the steps for a DK crush and Kulot technique. So our strategy is to simplify your steps in a Kulot technique. So this is already mentioned what are the markers and what are the advantages of Biomime branch system. And the last product. So one thing we all if I could compare this to a cricket match, nobody wants to get out in the last ball after scoring a century. So this is a very simplified version of a collagen device. It comes with 3 components. One is an anchor, which is made up of PLLA, polylactic acid, and then a bypass tube, and then a cap system. So the funda is very simple. Only 3 steps you have to follow to deploy this 10, which comes with 6 French and 8 French compatibility. So you don't want to exchange your sheath here. You can go with the same sheath. For example, if you are using a 6 French cordis of 11 centimeter, you can insert the same vascular closure device into that. And once it is deployed, you just pull back by holding the green marker and the tip, whereas you will be getting a identification marker which demonstrates you that the anchor has been deployed, which is demonstrated on the left side. So the anchor will be deployed into the perpendicular degree angle, and then you can pull the entire system outside. So by the time the anchor will be holding the vessel, and the only thing left is that to sandwich the vessel in between. So just give a push it inside, and the collagen will be getting activated. So since it is a collagen based device, 45 to 60 days you will not be able to repuncture, which is common for all the collagen devices, and the entire system the entire procedure will be done within less than 30 seconds.
Excuse me. Sorry to interrupt. Your time is up.
Yeah, that's it. Thank you.
Yes, thank you so much. Any questions from the moderators or from the crowd?
What is the difference between angioseal and this?
So in angioseal, you have to exchange the sheath. Here you have to take their own sheath and then you have to insert and re-access. Okay. Here you can use the same sheath. You don't want to exchange.
Like that angioseal. Okay.
Yeah. Angioseal you have to exchange. Here you don't want to exchange.
Okay. Good.
Yes, thank you so much. And to present the memento, I would like to welcome Veera Swami. And once again, can we give a big round of applause for Nazim Shah Nasrullah on the innovative Indian medtech company representing Merrill Life Sciences. Thank you so much. And the next speaker, I would like to welcome Gopal Madhavan on the topic Heart Recovery Program with Impella from Biomed. Can we give him a big round of applause, please, as we welcome him? Yes.
Yes. Good evening, all. Yeah, so this is not only a memorable day for you, but also for us as industry partners being a part of this program. Being the first international program being hosted in India, particularly South India. And unfortunately, people who have done Impella with me are not inside this hall. I don't think so they are inside this hotel as well. They have gone for shopping. So to introduce myself, probably I need to take that leverage of introducing me. Before that, I would like to share great news that globally we have done, last week we have achieved the milestone of 250th patient with Impella. So thank you, I'm honored. And in India, we have close to saved and served 250 hearts and still serving. With this, I will just give some preamble about the company and basic introduction about Impella and what do we do exactly when we talk about heart recovery with Impella. So, I mean, most of you don't know me. Few people who are sitting on dais, I know few people there. So I'm Gopal Madhavan, clinical consultant for Abiomed, directly representing Abiomed. And I take care of algorithm protocol framing for hospitals and doctors, physician education training, and right from the patient selection to the patient outcome. So with this, I will just go to the history of Abiomed. This is how to get into the slideshow. Yeah. So this is our brief history with 4 decades of experience in heart recovery and heart pumps and all these things. We are the first one to got this first FDA approved LVAD in the year 1992 and total artificial heart in the year 1981, in which, I was not even born at the time. So with this decades of experience, now we are comfortably sitting in one of the highly innovative and respectable product in the market, which is world's smallest heart pump, Impella. In 2015 and 16, we got majority of approvals for all the pumps, and recently in 2019, we got this approval for Impella 5.5 and Impella RP. So this is our entire family of pumps, I should say, right from 2.5 liters of support to CP. In our terms, it is cardiac power. In your terms, it is 4.3 liters of support, and 5.0 and 5.5, and RP, which stands for right-sided percutaneous, only intended for right heart failure. And if you see the support provided, as I said, 2.5, 4.3, 5, 5.5, and RP gives close to 4.3 liters of support. And the console, we call it as automated Impella controller, is same for all of these pumps. So you don't have to change anything with the console. The console is a very smart console which detects the pump and it takes care of each and every point of the pump in terms of patient care. And when I talk about Impella and unloading of your ventricle, dysfunctional ventricle, I mean it because this is the only available device as of now in the market which directly unloads your ventricle. You know what I mean, right? Direct unloading means just take your entire load of your ventricle and put it into aorta or just put it into outside, that's it. So if you take other devices which are available in this space, will aid in unloading, but it is not, we cannot call it as a direct unloading. It's an indirect unloading. Even ECMO or even IABP, it indirectly unloads your ventricle, but Impella directly unloads your ventricle. So the main advantages of Impella are this. As I said, it directly unloads your ventricle. So majority of your blood is being pumped into your aorta. So you have a very good coronary perfusion as well as your peripheral perfusion, which means end-organ perfusion. And with the advent of RV Impella, that is Impella RP, we can address biventricular shock as well as we can address right ventricular shocks. And we can easily escalate the patients from Impella 2.5 or CP to 5.0, which is a surgical axillary cut down. And the main advantage of this is you can ambulate patient easily at as early as possible rather than keeping the patient in a bedside or on a bed. And with this, I just show a small video. So audio is out. So this is the position of Impella, a little bit more deeper. Yes, this is the position of Impella. You can see the aortic annulus is accommodating the RO opaque marker, and the inlet is sitting exactly into ventricle, and the outlet is exactly sitting in ascending aorta. So the inlet should be free of intracardiac structures and other structures inside the heart. Most of the times we get a challenge here. We can address it through smart positioning. And this is the position so that your entire ventricle is getting unloaded. Yes, this is the Impella, the one which propels, the one which impels, that is the Impella. It's not a propeller, it is an opposite of a propeller. Propeller pushes, rather Impella pulls. So this is the concept of Impella, which imitates Archimedes screw, where it takes the entire load from one source and it gives into other source. And there are hemodynamic and physiological effects behind this Impella pump. If you see the inlet, there is a different physiology, and if you see the outlet, there is a different physiology. So this is exactly sitting in the aortic ascending aorta. It gives more than 90% of your volume which is being taken by the inlet. So it directly increases your cardiac output, it directly increases your mean arterial pressure. Since we increase both the things, cardiac output and mean arterial pressure, it directly increases your cardiac power output, which is a very new term being followed recently in all the clinical trials. It's a surrogate independent marker for mortality for cardiogenic shock patients. If your cardiac power output is less than 0.1 and it is decreasing, the survival chances of patients are very less. If it is showing an improvement or a kind of a good prognosing trend, your survivability is very high. So cardiac power output calculation is cardiac output into mean arterial pressure divided by a constant which is 451. So we calculate it when patients are on Impella, then we will closely follow those patients for titrating the values to be above 1 and 1.0. So this is the physiology behind this outlet, and if you see the inlet, this is the bigger physiology. But it's very simple. Since it is unloading most of your ventricle, it directly reduces your end diastolic volume as well as your wedge pressures. And thereby Laplace heart comes into picture, where your wall tension, microvascular resistance, obstruction is coming down. Thereby it increases your oxygen supply, thereby reducing your oxygen demand. It makes your ventricle completely into rest. Whereas in ECMO or IABP, there will be an increase in oxygen demand. IABP, there will be reduced demand, but still in ECMO, there will be an increase in oxygen demand, since your ventricle is pumping more than it was doing before with VA ECMO. So this is the anatomy and, this is the hemodynamic effects of Impella in the inlet. Indications, broadly classified, there are so many indications, but broadly there are two indications. One is the complex chip patients we are talking about, and the other is the cardiogenic shock. In complex chip patients, where we call it as a protected PCI, which means protecting the patients during a chip procedure with Impella. That's what this protected PCI mean. This is the multitude of patients who come under this category of complex chip patients, protected PCI. Basis their comorbidity, basis their complex coronary anatomy, and their usage of extensive invasive therapies on the patient. And finally, if you think the patient cannot withstand the hemodynamic insult for brief period of time when you inflate and deflate balloons, these patients come under a protected PCI category. And here the Impella acts as a mechanical circulatory support. It will never do any changes in the structure of the heart, but rather it does the supply of blood, and also it increases the coronary perfusion. So it acts as a mechanical circulatory support, particularly in this indication if it is truly a protected PCI patient. In cardiogenic shock, we all know when to address this spiral of death shock. You need to address the patient at the earliest, as early as possible, with proper intervention. And here the Impella acts as a recovery tool. So here the goal of Impella is to recover the heart. In protected PCI, it acts as a mechanical circulatory support. And we all know with Impella, you don't have to really stage the procedure. We have been discussing so many things, whether to do a complex culprit lesion along with the other lesions as well. With Impella, you don't have to stage the procedure. You can do the complete revascularization in a single setting, so that you can increase the survivability of the patients. This is one real patient with computerized arterial pressure tracings. You can see here, this is the history. And if with Impella, without Impella, this map baseline was 86. During balloon inflations, you can see the map is exactly reduced to its half. And now with Impella, even after putting Impella immediately, your map is at 110, and his map is still maintained at 97 even during balloon inflations and deflation. So it takes care of your peripheral perfusion very well. And the more complex your patients with anatomy, the more benefit is pronounced with Impella. I mean, single last vessel, surviving vessel, two vessels disease, multi-vessel disease, those patients with Impella will be more pronounced on the benefit rather than patients who are getting Impella with single vessel disease. But still, I am happy to treat single vessel because it's a business for me, but still just for a discussion sake. So Impella and cardiogenic shock, again a small simulated pressure tracing, which clearly shows that the physiology of inlet is working there. You can see the LVEDP baseline at 28, but now it has immediately reduced to 20 mmHg, and directly it reduces your wedge pressure as well. So patients who are on pulmonary edema, congestion, all these patients will get benefited immediately after implanting Impella in just minutes. And you can see clearly this map is also getting maintained at 72. So both your peripheral perfusion as well as your ventricular unloading is happening simultaneously in cardiogenic shock patients. Overall, Impella increases your map, increases your cardiac output, thereby directly increases your mortality factor, which is cardiac power output, thereby reducing your wedge pressures. And this is also interesting. We all see ABG reports reading more than 8, 10, and 12 in cardiogenic shock scenario. Impella has a potential effect on blood platelets immediately after starting Impella. We have seen theoretically, this shows 6, but theoretically I have seen close to 12 and 13 of lactates coming down to 3 and 4 in a couple of days after Impella. So that means your kidney is getting adequately perfused. And we are fortunate enough to get this technology, which is a smart assist we call. In India, I think a lot of technologies will get delayed because we know it takes 4 to 5 years after getting his US FDA and all these approvals to come into India. But we have launched this smart assist a couple of months before, and to be more precise, we have treated 13 patients on this smart assist technology. Smart assist is nothing but you can see the metrics here. Sorry for this poor visibility. You can see the metrics there, red, blue, and red, white, and green metrics. Basis this metrics, easily you can identify the patients who are going into right heart failure, and you can either augment the therapy or you can advance the therapy basis that conclusion. And you can easily reposition the pump without the need of any imaging modality like any echo or fluoro or something like that. But it is based out of a high fidelity sensors which is present on the pump and the console itself. And finally, you can easily wean basis these three readings. If his native heart is recovering, you can wean Impella immediately on the table. If his native heart is not recovering, you can put the patient on, keep the patient on Impella for a few more days, and finally you can check the patient status after a couple of days. So this is one advanced technology where your life and my life will be very smooth. I don't have to sit around you in the ICU. You don't have to slog your time in the ICU. We can go happily home and we can be on WhatsApp Connect. So exactly this is important what we do when we talk about heart recovery program with Impella. Once the hospital is identified that doing volume centers are identified, we used to request the doctors and multidisciplinary team to take more chip cases so that your outcome is 100%, not less than 100% for complex cases. It's just because to make you understand more about Impella, how it acts on the patient, what is the hemodynamic stability it offers on the patient, and what are the troubleshooting you are undergoing while putting Impella on those specific patients. Because in cardiogenic shock scenario, we don't have the time to analyze these things. Once the patient sets, the cardiogenic shock sets, we all will be running on our toes like to how to revive the patient from that scenario. So it's not the proper time for us to learn. So just to have a proper learning on Impella, this is what we say, accumulate some 3 or 4 cases on protected PCS, give you a 100% effort and 100% outcome, then you can plan cardiogenic shock patients. And once it is set, probably we will sit and discuss with your multidisciplinary team, including your perfusionist, CTVS surgeons, cardiovascular surgeons, and all vascular surgeons, including heart failure specialists and cath lab technicians. Of course, we cannot leave you, for a proper protocolized approach with some algorithms. We will be sharing like Innova Heart protocol and all these things, how they have formed the heart team. And finally, we will take the call, and we will also share some algorithms and protocols with you. And finally, we will help you for a couple of cases as hand holding. Then after that, you can take on of your own cases. And people like me who slog around in the field for with your patients for 24/7 are available right from the pre-implant considerations to till the patient is getting weaning and explanted till they go home. So you don't have to worry about any of your case supports. We are always there to support you. And these are all some guidelines which says class 1 and class 2A indications for recommendations for Impella. And this is a recent consensus which is being drafted by our Indian doctors. You can see the names, top big names, Dr. Sheth, Dr. Rastogi, and Dr. Roni Matthew from Kerala, Vijay Trehan, in consensus with Dr. Rajiv Tayal and Sanjog Kalra about the protocolized approach for CHIP patients basis the scoring on risk assessment. Clinically, you can see this assessment like LVEF and renal dysfunction, age and ACS, already having a valvular disease, and that is a technical aspect like what are you going to do? Is it a complex case you are going to take, or is it a rota-based case, or you are going to do antegrade or retrograde CTO basis that you have scoring system there. If a patient falls under this less than 3, then you don't have to, you can go for traditional, conventional, unprotected PCA, I should say, without Impella or without anything, just keeping your IABP as backup. If the patient falls between 3 to 5, you should consider Impella, basis the cost and all these things. The patient score is more than 5, definitely you have to counsel the patient for Impella. And we are proud to get this thing published in Asia Intervention recently. And this is my last slide. In spite of all these advanced therapies and protocols and your meticulous work in the cath lab and critical care, still the mortality in cardiogenic shock is more than 50%. And if you see the post-discharge mortality in AMI cardiogenic shock, it is more than 50%. So I just like to finish the presentation with a statement. I think time and decision, what time the patient comes and what time you are in and what decision you are taking to wean with what or to treat the patient with what, that makes the muscle to reduce the mortality. Thank you. And again, a big congratulations and all the best for the team here and the committee members. And I request them to do more and more meaningful events for, for this group so that we have some good, great discussions again. Thank you and wish you the best of it. Thank you.
Yes, thank you so much. Can you...
Hello? Yes, sir. Yeah, yeah. Yeah, yeah. Exactly. So we never have any issues with hypothermia because we are not taking it extracorporeal. So it's intracorporeal, microvascular, continuous pump, but not constant pump. So we don't have any issues with hypothermia. If the patient is already cool and clammy because of his case presentation, because of his clinical presentation, then we will never get an LM because of this hypothermia. If malposition, you are absolutely right. First, it starts with reduced diastolic and systolic folds. You can see on the left side of the screen. The diastolic and systolic folds will not be having a pressure gradient or a difference in the gradient. Suppose the diastolic reads 3.5 and the diastolic reads 3.5 liters and diastole may read 3.1. So just 400 ml would be the difference between the systole and diastole. So from that point onwards, we can clearly identify that it is a suction alarm. So suction alarm, its impella is volume dependent, highly sensitive to volume. If you don't have volume in LV, you will get alarm. If there is an impending RV failure, you treat RV first and then put impella. It doesn't make any sense for us to put LV impella without treating RV. So either you correct the volume, and if you, even after you correct the volume, there might be some clot inside impella, you have to replace the pump if it is not getting addressed, or it might be an impending RV failure, just correct that RV failure. That's what we recommend to go for swan guns. Again, there is a big debatable topic of whether to put swan guns or not, but it gives exactly the pressure gradients and the PAH, pre-capillary and post-capillary PAH. So we can easily identify between these pressures, and we can have the ratios of PAH as well as we can ratios of RA. Basis this, we can tailor the therapy, whether the patient is really in hypovolumic or hypervolumic, or he is into RH failure. So this is what we recommend. So the suction alarm can be addressed in these 3 ways.
What is the maximum time period we can keep this?
Sir, as per the IFU, we have kept this all pumps except 5.0, we have kept it up to 9 days. But as per the IFU, it is 5 days. 5.5 and 5.0, we can keep it up to 30 days. So usually what we say, this 5.0 and 5.50, it's a surgical mid-axillary cut down. You can keep this pump as a bridge for either LVAD, or when you have a heart in front of you in next week or something like that, you can keep this pump, making the patient as a bridge for transplant. So ACT, if the patient is getting admitted with impella in critical care, we recommend quarterly ACT, and it should be like close to 160 to 180. Heparin. Usually we used to have this heparin flow in impella. It maintains the required ACT. Yeah, it maintains that ACT. Still, if the patient is not maintaining that ACT, probably we need to check his coagulation status, and then we need to take a call. And if you want to reduce the heparin, we can make it 0 heparin. We can use sodium bicarbonate as a purge solution. That is recently approved FDA sodium bicarbonate. Thank you.
To give the memento, I would like to request Mr. Girish Gopinath. So once again, can we give him a big round of applause, Gopal Madhavan, on the topic of heart recovery program with impella. Yes, thank you so much. And next, I would like to welcome Mani Chabra on the topic of emerging technologies for simplifying PCI's Viva Scientifics. Can we all please give her a big round of applause and welcome, please.
Hi, good evening everyone. My name is Mani Chabra. I am the marketing manager for Viva Scientific India. So Viva Scientific, we have been established with a vision to bring the innovative and advanced medical devices in India, for those products who don't have their direct presence in India. So we have been associated with different organizations like Spectronetics and have bought some of their beautiful products like excimer laser. We are the pioneers of in bringing the excimer laser in India, and as of now we have some 25 installations all across India. in different hospitals. We have also been associated with Spectronetics for their lead management portfolio, and being in the industry for last almost 13-14 years, we know that the cath lab technicians, they play a very important role when it comes in the decision making for any product, what to do in the cath lab. All the doctors, they depend upon your advice, and they look up to you even for a simpler case also. To your advice and your judgment helps them in making the right choice for the patient. So and you are the most important, and you should be aware of all the latest technologies which are there in the market in the India, and all those latest innovations which are coming on. So we also are associated with different companies, like one of the organization, Nipro Medical Japan. So we have bought their guide extension catheter by the name Guide Plus 2 in India. So Guide Plus 2 has many advantages, and it scores over the other guide extensions quite beautifully, I would say. It has So there are three important features which helps it making it different from the competition, from the other products. So it has a smooth and round resinous tip which helps in easily navigating, and it's a atraumatic tip which doesn't cause any dissection in the artery when you navigate this. We have seen that by using a guide extension, we require a balloon to drag it across the artery so that it should not cause any dissection. So this has been taken care by the Nipro. So the tip is quite flexible, it is resinous, it is atraumatic. Another thing is that the Guide Plus 2, it has all the hydrophilic coating, and it is all braided tubing which helps in providing the crossability and the pushability. And the tip is resinous material, so it leads to more trackability. And the device entry port in the Guide Plus is quite large. It is a skive design. So usually the guide extensions which we have in the market as of now, they have a half pipe design. So whenever we take, sometimes we take a stent or a balloon across the guide extension, it may cause the stent or the balloon to damage while retracting. So Nipro has taken this into account, and they have made the device entry port quite large. So we have two variants of Guide Plus 2. One is Guide Plus 2 ST, and another one is Guide Plus 2 EL. Guide Plus 2 ST has a tapered distal shaft which tapers from 5.3 French to 4.7 French, and it has an inner lumen of 1.33 mm. While Guide Plus 2 EL, it tapers from 5.3 to 5 French only and has an inner lumen of 1.43. Guide Plus 2, we can use it with all our normal devices like angioscope, stents, balloons. And for bulky devices, Guide Plus 2 EL is important. And we all understand that guide extensions, they are quite useful for tortuous anatomy, calcified lesions, while recrossing through the stents, maybe delivering long stents, they are very useful. So in such cases, we can use a Guide Plus 2, and it will be very beneficial. So another product from Nipro, which we also have in India, is OK2. OK2 is after the name of Dr. Osama Kato. He was the one who built this product. As of now, we have sold almost more than 10 lakhs in units in India. So OK2 has two important features. One, it has a dual valve. One is a hemostatic valve, and the other one is the fixed valve. So hemostatic valve, you can press it and it will get open. We can put the devices, manipulate the devices, and then it can also be, then by removing the finger, we can close it. And this yellow mouth, if you're seeing it, if you rotate it clockwise, it will get open. So we can remove different, so if different products are inside, we can remove one, and then, by rotating it anti-clockwise, it will again get closed. The fixed valve is quite important and has a very important feature. Sometimes what happens is when we are doing a complex case and we want to fix the device, a device or a catheter or a micro catheter to a position and then put across the stent and play with the other devices. So by rotating the fixed valve, we can hold the catheter or the micro catheter and fix the catheter, and then we can play along with the guide wire or the stent or the balloon. So two important features, the goal for hemostatic valve is to reduce the blood loss to a minimum and for easy device movement. And we all know that if the blood loss is minimized, we can the patient burden will be minimized and he'll have a faster recovery. And also OK2 has a inner inner lumen of 10 French. So heavier or high profile devices like a rotablator or during the KBT technique, we can use OK2. So another organization which we are associated with, and we started Viva Scientific, one of the first organization is Brosmet. One of their latest product which we have which we have launched in the market is Alveo HP, which is a high pressure balloon, and it is the smallest profile balloon diameter catheter available as of now, and it is for the treatment of the CTOs and the complex lesion. So the smallest So the features and the benefits of Alveo HP are, it has the ultra low entry profile, ultra low crossing profile, and ultra low balloon diameter. We all know that for CTOs or tortuous vessels or a complex lesion, we need a tip entry profile which is quite low, and it should be smooth and so that it can easily cross the lesion. So the tip entry profile of Alveo is 0.015 inches. Quite low as compared to a guide wire, and the distal shaft of the Alveo HP, so it is all welded, it is all smooth, and they have removed all the hardness. It is all smooth tapered, so the tip is quite flexible. Also for a CTO balloon, it should have a quick rewrap. So for Alveo HP, they have optimized the balloon material, so it provides a superior rewrap for the CTO lesions. So while entering and re-entering, it has a superior rewrap. And also, as we discussed, that it is all welded, so the transition is quite smooth, which helps in the low crossing profile of Alveo HP. And the shaft is all, so it is a spiral cut hypotube, which helps in the smooth transition, and it increases the pushability. So as I said that it is the smallest diameter which is available in the market. So the smallest size available for Alveo HP is 0.75. It has a RBP of 20 atmosphere and an average burst pressure of 28 atmosphere. So even if you go above the RBP, the chances of balloon rupture will be quite less. And we have seen even in the 1 mm diameters of the balloons, the RBP is quite low. It is 13 or 14 atmosphere. So Alveo HP, being a semi-compliant balloon, it offers a very high RBP with a low entry profile and low crossing profile, suitable for all these CTOs and complex lesions. So the diameter of the Alveo HP is, so it starts from 0.75 with a quarter size increase till 2 mm, and the length is 5 till 30 mm. So now our BDC portfolio is, so now it includes Alveo HP along with Apollo NC, which is a non-compliant balloon from Brosmet, and R-Times, which is a semi-compliant balloon catheter, same from the company Brosmet. So next product which we also have in India is the angiosculp from Spectranetics. So Viva Scientific, so at Viva Scientific we take care of the marketing. It's a scoring balloon catheter. So they have now changed the profile of the angiosculp, the design. It is a tapered tip now. So few of the features for angiosculp is they have molded and they have made the tip tapered, which helps in the delivery, which provides a superior deliverability and provides a smooth transitions throughout the distal end. Also, the angiosculp has a nitinol, it has a helical design with electropolished nitinol struts. So we all know that nitinol has higher elasticity, and with angiosculp there is a higher so there is a quick deflation time, and angiosculp offers a large working range for of RBP 20 atmosphere. So the same balloon device can be tailored to the different vessel size. So for a so for a single vessel with diffuse lesion, the same angiosculp can be used at different pressures to make the vessel bed. So the few indications which angiosculp has been approved for: the calcified lesions, ISRs, predilatations of the complex lesions, bifurcation lesions, ostial fibrotic lesions. We can use it for diffuse lesions. Prior to rota, it can be used, and for underexpanded stents. Also, we have Rivas and Epitome, our coronary stent system available in India. So Rivas has a 60 microns ultra thin struts with a biodegradable and biocompatible polymer with the hybrid cell design, open and closed both. So these are the products which we have for with Viva Scientific. That's it from my side. Now we are open for discussions. Thank you.
Yes, thank you so much. Is there any questions from the audience or the moderators?
Yeah. Actually, it is moving slow, I think. Yes. Yeah, we will add. We are about to launch it.
Pre-launch marketing challenge. And क्या बोलते हैं उसको?
Guide plus 2. Is it? Okay. Is it the NY guide extension? Okay. Okay. So let us know. We will report it. Yeah. Yeah. This one. So, sir, this is the tip for the guide extension. So it has a resin material. Resin is a polymer, so. Yeah. So usually the guide extensions, they have metallic ring at the tip. So this has a resin material which is quite soft, which is quite flexible. It is round tip. It is atraumatic. So when you drag it across the anatomy, it will not cause any dissections or perforations. So usually we use a balloon with a guide extension. Other guide extensions like Guidezilla, Guideliner, all those things. Yeah.
This is 6 French compatible or 5 French?
It is 6 French compatible. So it tapers from 5.3 to 4.7. It's 6 French. Yeah. Okay. Thank you.
Yes, thank you so much. So to present her the momentum, let me welcome Nagarajan to the stage, please. Yes, so once again, can we give a big round of applause for Manisha Brown, the topic of emerging technologies for simplifying PCIS from Viva Scientific. Thank you. So we are almost at the end of the session, and we have like 2 presentations left. So next I would like to call upon Deepak Mondal, redefining strategies and catalog at ABBAT.
Hello.
Yes, people who are not going for their refreshment, I request you all to be
Please be
seated.
seated, please.
The seats in the front are vacant, so you can actually come forward and sit, yes. Yes, so once again, let me welcome Mr. Deepak. So can we give him a big round of applause for his presentation? Yes.
Hi, good evening all. My name is Deepak Model from Abbott Vascular. I'll just take you through redefining strategies in cath lab with Abbott. Just a moment. Yeah. So inside the cath lab, basically doctors are considered to be God, as they treat patients, saves many lives. But we also believe that technicians are magicians, as they work very closely with healthcare professional and help them getting better patient outcome in inside the cath lab. So I feel you deserve a very big round of applause. So please give a big round of applause to each one of you. Thank you. I'll just take you through a brief journey of Abbott. So Abbott was established in 1880 by Dr. Wallace, and since then it's been improving life for more than 125 years. From 1930 to 1960, Abbott expanded its business in vitamins and later into infant formulas. 1970 to 1980, it enters into diagnostic industry, and since 1990 to 2000, we are a dominant player in medical device industry, and since today we have been helping patient having positive outcome in health all over the world. So among all hardware, guide wires are the first to enter the coronary circulation. I would just like to play a 2-minute video. This is just to showcase the amount of effort that has been taken by R&D team, engineers and the technician, to manufacture one guide wire. Do we have volume?
Volume, please.
Okay, it is just 2 minutes, so it will just finish very fast. Okay. So did you notice one thing? It takes team of 45 experts, 8 days of hard work to manufacture one guide wire, though it looks very simple. Okay, this is the most important accessories when it comes to coronary angioplasty. So Abbott places its guide wire in 2 different buckets. One is workhorse and other one is specialty guide wire. Most of you, or rather everyone, knows about the guide wire, and you have been already using this guide wire day in, day out in your cath lab. So workhorse category, we have got BMW Universal 2, Powerton Flex, Ultra Flex, and in newer variant we have got Versaton and Turn Track. And specialty guide wire to cater to your tortuous anatomy, difficult lesion, and where you need good extra support. Also in CTO segment, we got Whisper, Pilot, Ironman, All Star, cross it and progress in CTO category. So you take any guide wire which is available in the industry currently, it is completely based on these 6 building blocks of the guide wire. And these 6 building blocks are core material, core diameter, core taper, and among these external component is coating, coils and covers, and tip design. So these are the 6 major building blocks of guide wire. You tweak any building block of guide wire, this will change the performance of guide wire. For example, you take the core diameter. If you increase the diameter of the wire, it will increase the support and torque, but the flexibility will compromise. And if you reduce the diameter of the wire, support and torque will reduce, but flexibility will increase. Similarly, all other building block attribute to some or other function of the guide wire. This is a very old guide wire, and you have made this guide wire a #1 guide wire in coronary industry, BMW guide wire. And based on your feedback and suggestion, we have made some little modification and we have launched BMW Universal 2. So basically BMW was hydrophilic coating guide wire. It was fully hydrophilic coating guide wire. And with BMW Universal 2, what we have done is distal end is hydrophilic coating and the proximal end is polymer jacket. So we call this an intermediate polymer sleeves. So this will help you track through your tortuous anatomy in workhorse cases. And when it comes to, if you compare both BMW and BMW Universal 2, both the attributes remain same except in the last part, trackability, where BMW is fully coated wire, whereas BMW Universal is partially hydrophilic as well as polymer jacket. In specialty guide wire, we have got Whisper. Whisper is fully polymer jacketed wire. This comes in 3 variants in Whisper LS, Whisper MS, and Whisper ES. This helps you track through tortuous anatomy. And in Pilot 50 is again a fully polymer jacket wire. This helps in this helps in tight lesion, and this is also preferred wire in ACS with very high thrombus burden. Crossit comes in our Abbott CTO family wire. So this is what Pilot, Whisper and Whisper, the design looks like. This is core to tip design. This has got parabolic transition technology, and this has got hydrophilic coating with full polymer jacket. CTO I'd like to skip. I'll just spend a little more time in this coming 2-3 slides. This is a new guide wire which we have launched in Abbott portfolio, in Abbott family. So of late there is steady increase in the success rate of CTO with unchanged complication and increased complexity in the patient. So when you feel that your normal guide wire like Gaia 1, Gaia 2 or Pilot 150 or Pilot 200 fails to cross the lesion, okay, that time you can think of penetrative guide wire, which is Infiltrate and Infiltrate Plus. These are the 2 new guide wires which we have recently launched probably a few months back. So let's have a look at what is so great about this guide wire. So there are 3 major advantages. It has got micro texture tip. You can see the tip of the guide wire. This is 0.009 and the tip of the guide wire is micro textured. So unique micro texture tip for cap engagement. So because of the texture, it sits on the cap and it doesn't slip. Second attribute is it has got tapered tip for better penetration and uncoated tip for good tactile feeling. Also, it has got, for the first time, any penetrative wire in the market is pre-shaped micro J. What I mean by this is, if you see the last 1 mm of the guide wire, this is pre-shaped at an angle of 25 degree, which offers better tracking, better navigating through the vessel, and that 25 degree angle also offers you better large surface area to penetrate the cap. So whenever you have next opportunity with very hard CTO cases, you can just try it out. Infiltrate, it comes in 2 variants, 11 gram and Infiltrate Plus 14 gram tip load. Also, another workhorse wire that we have recently launched probably a year back, just before I guess, okay, I think I missed one slide somewhere. Okay, turn track. This is another guide wire which we have launched just before the COVID. So this is again a 19-nol material wire. The special feature of this wire is this has got tip shape memory. So once you shape the tip of the wire, guide wire, this will not lose the shape unless and until it is reshaped again. So whenever you have got any tough complex lesion where you need to spend more time, which longer case, you can think of turn track guide wire. This is 19-all core to tip design, and this offer excellent torque, 1:1 torque, and very flexible. The other major engineering which has been done with this guide wire, normally the working length of guide wire is 19-all, and the non-working length, which you see in green in color, this is always stainless steel, and in between there is hypo tube. There is hypo tube for all traditional guide wire. But with the turn track, the engineering marvel what has been done is this hypo tube has been removed, and with special welding technology, this has been heated at 200 degree twice, thrice, and this has been fused in such a way that it has got similar diameter, so that since there is no hypo tube, the force transmission is better and can easily navigate through any challenging anatomy. It comes in two variant, 0.8 gram tip load and 0.6 gram tip load. 0.6 gram tip load is called as turn track flex. This is very similar to run through guide wire. If you see all the attribute when you compare with turn track, both are very similar, both are 19-all. The tip coating with turn track, we have got fully coated, and one other variant we have got last 1 centimeter which is uncoated. Tip material both are 19-all, tip load 0.8, 0.6. This is very similar to run through guide wire. The only difference between run through and this, run through the tip is flattened, whereas with turn track it is round so that it torque easily. It doesn't give the whip unlike a flat tip. We have got one more wire which is Versatin, which is very similar to turn track wire. The tip load of Versatin is 0.8 gram. So whenever you need any softer tip, you can look for turn track, and you need a very stiffer tip based on the anatomy, based on the lesion, you can look for Versatin. So coming to Abbott BDC, I'll just wind up very quickly. We have got mini track, track and NC track. This has got very soft tip technology, low multi-layer cross-flex balloon, and this has got skive hypo tube, which means the hypo tube is cut into skive design so that it is kink resistance, and the force is transmitted to the distal end of the catheter. It is 0.0017 tip entry profile, soft tip technology for excellent push efficiency. The major advantage with this has got larger size matrix, more than around 77 sizes are available with with track and mini track. NC track, I'll just run through one slide in NC track. If you see, NC track has got very flatter compliance. Let's take an example of 3 mm NC track. When it is dilated at 12 atmosphere, which is nominal, it is 3 atmosphere. But when it is dilated at RBP of 18, it just becomes 3.1. And when it goes beyond RBP at 22 atmosphere, it becomes 3.2. So it shows that NC track is a very flatter compliance. And once again, it comes with very large size matrix, which has got 59 sizes. And coming back to our stent family, we have relaunched once again Xience Alpine a few months back. This is a gold standard stent in Xience. It's a gold standard with more than 125,000 patient randomized clinical trial. The most studied stent, not take much time. Just go to the stent designs. This Xience Alpine has got coaxial positioning system and a flexible tip. What does it mean by coaxial positioning system? It reinforced proximal shaft for improved pushability. So if you see this coaxial positioning system will always help the stent to center the vessel wall, true tip center. This will never bias the vessel wall. So it will easily track through any calcified and challenging anatomy. The balloon is dual layer. Inner layer is thin and the outer layer is strong, so it gives flatter compliance. The most important aspect of this stent is it has got precise stent platform. That is mid marker to mid marker. There is no other stent in the industry which offers this benefit. If you compare with any other stent, there is always a distance of 0.6, 0.8, 1.2 mm from company to company. But Xience is always at the edge of the stent, and it offers precise stent placement in osteal lesion, in bifurcation, also in minimal overlap. This also has got sky shape hypotube, so there is no kinking unlike any other stand where the mandrel is welded. And this is my last slide. Thank you so much. If you got any questions. Yeah, Whisper LS offer very less support. Okay, so if you want to track through very simple tortuous anatomy where MS is not tracking through, okay, you can try for Whisper LS. It's available. But usually almost 95% of cases when it comes to tortuous anatomy, Whisper MS is preferred most of the time. Okay, Whisper LS is probably not much talked about and very less preferred wire. Less preferred wire because of the anatomy probably. Because Whisper MS can track through any anatomy, so there is no need of LS until and unless Whisper MS fails to cross. Microcatheter, so if it is a very challenging anatomy, then you can take a microcatheter support definitely. Right. Microcatheter, yes, yes. Correct, correct. Yeah, turn track wire is available. It comes in straight tip, it comes in J tip. Turn track is available in 4 variant, 190 centimeter. It is available in J tip, straight tip, and it has got fully coated tip and uncoated tip. Uncoated when I means by last 1 centimeter is uncoated. Okay, like some physicians prefer very good torque response. So when it is fully coated, the torque may get compromised. For those physicians who prefer very good torque response, they order for uncoated tip.
Is there any question from the audience?
Whisper has very, what is the tip load with Whisper?
Whisper LS is 1 gram and Whisper MS is 1.4 gram.
It's a tapered, no?
No, it is not tapered. It is not tapered. CTO only cross-it is tapered. Cross-it. Both all are cross-it family is tapered. Rest all other wire are responses parabolic grind. That means when we taper the wire, when there is multiple 2-3 taper, then the wire may prolapse in the bend. Okay. But when we have got responses parabolic core, that is uniform and then it is gradually coming down, it doesn't prolapse in the bend. It takes the bend very easily. So all other wire there is joint, only in turn track there is no joint. Because turn track, the non-working length is stainless steel, whereas the working length is nitinol. And it is not easy to weld the stainless steel with nitinol. So with different technology, engineering, it has been welded and made like one single material. Rest all the wire, there is in between a hypotube, which compromise the pushability or it may kink in the resistance lesion. All-star wire is stainless steel, correct. All-star and Iron Man both. Yes, yes.
For Iron Man, it is increase the rail factor or what? Excuse me? For Iron Man, it is increase the rail factor.
Sorry?
For Iron Man, it is increase the rail factor. For tactile feeling, we can use for miscellaneous cases like CRTP, lead replacement.
So Iron Man is basically used like whenever you want to deliver a device. Okay, you need a good support. That is the only time you use Iron Man and then you exchange the wire.
Radial strength is very much supported. That rail factor is totally increased.
Yes, yes, correct.
What is the tip load of Whisper ES?
Whisper ES. ES is again 1.4 gram.
Okay, and sometime while tracking the balloon, it came back. While tracking any wire microcatheter, it came back. Automatically.
Whole wire comes back.
Why it is like that?
Wire is so soft, if even if the assistant keeps the hand, the wire comes back. It is very, very precise.
See, Whisper is a very slippery wire because it has got a hydrophilic coating and over that there is a polymer jacket. Okay, so it becomes very slippery wire. Yes, yes.
So are we done? Any more questions?
Thank you so much. Thank you.
All right, to present the memento, I would like to welcome Suresh Pandit. And so once again, let's give a big round of applause for Mr. Deepak, redefining strategies and catalog by Abbott. Yes, thank you so much. And next, I would like to welcome Jess Smith on the topic of meaningful innovations for your workhouse cases, representing Medtronic. Can we give a big round of applause and while welcoming, please? Yes.
So first of all, greetings from Medtronic, and thank you very much for this opportunity. It's an honor here to present in front of this August gathering here. And my topic today, which I'm presenting on behalf of my colleague, is on meaningful innovations, which Medtronic has been doing for many years now. And today I'm going to talk about for those workhorse cases, because for us, for you, every case matters. Now, DES, we all know, it's a drug-eluting stent, but when it comes to Onyx, there's a slight addition of terminology. We call it as a deliverable, efficacy, and safety, by which we would like Onyx to be known as. And when we talk about this, I would like to talk about all the different aspects of innovation that we have brought in. And specifically, if we look into the design per se of drug-eluting stent Onyx, if you see on the left-hand side, which is the traditional style of manufacturing any of the stents, which is by a slotted tube design, which is just laser cut. Whereas Medtronic came with a patented technology of having a modular design, which makes it much more flexible and with a rounded strut. Now, this is one of the innovation. We realized that it is giving a lot of flexibility, a lot of approach towards going to the distal lesions, but we did not stop there. We came up with the next innovation, which is in terms of a sinusoidal ring, a single wire technology by the name of Resolute Integrity, and that added more flexibility. The cases which were very tortuous in anatomy, even they were able to be taken care. So now from deliverability, now we also worked upon another aspect which is very important in doing complex cases, left main bifurcation, that is radio opacity, the visibility of the stent. And for that, the latest innovation is Resolute Onyx, which is basically having cobalt chromium and platinum iridium, which increases the overall the radio opacity of the stent. So as one of my colleagues also talked about, marker to marker, we say it is not just the marker, but is the entire stent and the visibility of that particular stent. So here what I talk about, the innovation, the rebranding, the new innovation that has taken place, that is what Medtronic offers, where if you see many other companies, they're just renaming with slight changes in their technology. So practically, it's altogether a new technology that Medtronic is bringing with every stent. Well, that gives you a lot of advantage when it comes to various other aspects to manage different cases. When we talk about deliverability, and you can see the score here, that is the lowest amount of force required to deliver the stent, and that is there with Onyx, the bench test data shows. Similarly, when it comes to overall in terms of visibility, which I was talking about, you see one of the highest visibility. So this is an image which is taken from an X-ray imaging, and you can clearly see the stent. So you don't have to really wait to see a marker and then place it as precise as possible. The stent itself is so much visible that you can just have a precise placement with that. Similarly, as I talked about, platinum iridium that has been added in Onyx, which actually is a much more denser material which provides more strength. So specifically in cases of osteal lesions, in cases of left main cases where you require a lot of radial strength, again, Onyx gives you a much more advantage as compared to any other. Another advantage for some of the complex cases is overexpansion capability and the overall size matrix. From 2 mm to 5 mm, you have all the stents available. And one of the biggest overexpansion capability that Medtronic has with Onyx is going up to even 6 mm. Would also like to highlight here that it is not just overexpansion, but in fact maintaining the overall the stent per se. There's no stent fracture, polymer fracture, even if you do an overexpansion. And one of the highest overexpansion in the industry. Again, managing some of the bifurcation cases, you get one of the biggest side branch excess cell area, so that gives you that advantage. Similarly, when we talk about the overall expanding of the cell size per se, again you can see where Medtronic Onyx gives you one of the biggest one. So we talked about all the features and how it is adding value. Now we talk about the deliverabilities and the safety aspect of it. And this is an internal data, we call it as a OCT study that has been done, which actually shows you how the stent has been placed, and specifically in cases of high bleeding risk, dual antiplatelet regime, this has got a US FDA approval to discontinue or interrupt dual antiplatelet in some of the high bleeding risk cases. So that's again one of the major advantage that you find with Onyx. So we talked about efficacy, now we talk about safety. Again, if you look into this long-term data, which is actually showing a very reduced number or lower number of stent thrombosis event. And you see a significant difference of close to about 86% lower incidence of stent thrombosis. So there are a lot of data available. We have another data, which is the Onyx One global trial done in about 2,000 plus patients. And this was primarily done again to find out what is the relevance. This was done against one of the stents which were available in the European area, Biofreedom. And the advantage that again you see here, that you had a very lower chances of stent thrombosis even up to 2 years. So in terms of efficacy, in terms of safety analysis, Onyx provides you all those advantages. Well, also talking about Rolex study, another data that we have, which, and if you look into all the different clinical outcomes in terms of TLR and TLF, again we show a very lower rates of incidence. Very importantly, there was this trial done, a 2 mm trial, in which we had performance goal. It was taken at 19%. However, when the trial was done, the number achieved was just 5%, and that gave an additional advantage. And this was given approval at different consortiums to be considered as one of the stent to be chosen specifically in high bleeding risk and in cases of wherever you are looking for safety analysis. So just a glimpse, of course there are many other data, but like to restrict to just giving you a brief idea about Onyx per se. So thank you.
Yes, thank you so much. Is there any questions?
Above 3 millimeter, all stents are same. You can expand the stent, any stent up to 4.5, 5 millimeter. Why you guys taking so much effort?
So for every stent, of course, there is overall geometry that has to be maintained. And then you have the cases like you have a tapering diameter requirement. So if you have a 4.5 diameter and you have a vessel which has got a distal stent or distal area of just about 3.5, of course you would not like to put in there. So you need to have those different sizes to take care of those tapering arteries.
You mean to say the stent is same, only balloon is different?
No. There is a pot that is done in which is of a diameter.
I'm just asking you one question: whether this above 3 millimeter, all stents are same.
No, we have even if you look into the overall number of elements, even that is increased. The overall the laser fusion pattern, that is also different. So it is not that all the entire range from a 2 mm to a 5 mm will have exactly the same. There is a step up that is given to ensure the geometry. Yes.
About 2.75 to 3.5, the stays the same, no?
Yes, in that particular range, it is same. Yes.
Is it true that your stents are good for diabetic patients?
Yes, of course, sir. We have a plenty of data which talks about benefit to the diabetic patients. Okay, maybe it's a yeah. Okay, I will take your point. In terms of availability, we can definitely look into on a case-to-case basis where we are finding that challenge. It could be related to the overall number of cases or particular incident. So we can always ask our representatives to have a quick check on that. Sir, the inputs that we have received from all across, they say they find that to be one of the highest. Again, it could be, I would say, the imaging modality that is used, the under fluoroscopy. So it's an individualistic approach across globe. That is the feedback that we have get, and what is the bench set data is what I'm presenting.
So we have done, excuse me, so we have done 3 cases. We have done 3 cases.
Okay.
So side branch was impeached. Side branch, there is no side branch significant stenosis was there. So we have done main branch stenting. So after thereafter, there is significant impeachment of side branch. There is any study, randomized study for Resolutonics?
So randomized study about side branch access?
Side branch access for any kind of further open cell strategy or any kind of thing?
Yes, so we have a study available which actually is basically devoted towards side branch preservation as well as side branch access, and also in terms of the overall when it comes to bifurcation, it has been considered and or I would say approved by the European Bifurcation Club, specifically considering these aspects. So for not just 1 odd year, for a number of years, they have really approved Onyx to be used as one of the stents when it comes to side branch, and that would be primarily because they are either getting a good side branch preservation. That means the chance, and that is primarily because of the open cell design. Every element is not laser fused. So if you would have seen the geometry of the stent, you will find there are a lot of elements which are non-fused. So the chances of Onyx stent obstructing a particular side branch becomes one of the minimal ones. And that is why they have
there's the abdominal one. Abdominal.
No, so it's in terms of opening up towards the side branch.
That is for precautionary of neoatherosclerosis or de novo lesions.
Sorry, I didn't get your question.
Neoatherosclerosis or de novo lesions.
Okay.
To restrict that, any kind of data you have? Hyperplasia or neoatherosclerosis for de novo lesions.
Okay, sorry, I didn't get the complete question.
Yes.
Sorry, I didn't get the complete question.
Okay.
Yeah.
Yes, I want to ask the de novo lesions that we can use it for abdominal, that kind of.
If you region is de novo, we can use the Onyx.
Yes,
for neoatherosclerosis, that is the point of view.
Of course, it can be used. Yes. Yeah, please. Go ahead.
Onyx has a biocompatible polymer, which is a Biolix polymer. Because of this Biolix polymer, which is more biocompatible towards the artery, that is why you have more albumin binding and more fluorescence.
And excipient, there is any excipient used for that?
No, we don't have excipient. We have the Biolix polymer.
Okay. Direct polymer.
Which is more biocompatible. Any polymer available in the market.
Okay, thank you.
Yeah. Thank you, sir. Thank you for this opportunity. Thank you.
Thank you. So to present the memento, let me welcome Baba Patil. Yes, so once again, can we give him a big round of applause for meaningful innovations for your work host cases, Medtronic. And the next we have Rakesh on Hawk 1 saving limb, saving life from Medtronic. Once again, can we please welcome him with a big round of applause. So this is, I think, the last session of the day, yes.
I'm guessing it's my session is the last for this evening, so I'll be taking it like a little bit higher. Yeah, you know the how the it's not it come. Yeah, so the topic given to me like Hawk One, it is another innovation from the Medtronic when it comes to the peripheral intervention. So the tagline for the Hawk One is the saving limbs, saving life. So what exactly the Hawk One is? Hawk One is nothing but the directional atherectomy. The way we have the rotational atherectomy in coronary, we have the directional atherectomy system in the peripheral artery disease. And which are the artery are indicated for this Hawk One therapy is SFA, TBL, popliteal, and few BTK. Which are the contradiction for this, atherectomy is like we can't use this directional atherectomy in coronary arteries, carotid artery, iliac, or in renal arteries. Now, how this Hawk One, where exactly the Hawk One should be placed? We all know that when we do the PED patient screening, or the doctor do PED patients, patient screening, they do the PTA, that is the ballooning. Then after that, they go for the stenting if required. If the stent gets blocked, then patient has to go for the bypass or amputation. But exactly we are stopping there itself. We are putting the Hawk One or directional atherectomy in between the DCB, PTA, or DA. So exactly we are stopping to put the stent. You can take a directional atherectomy into the peripheral artery where the disease is there, and you can again ask patient come back for the screening if he has any symptomatic or asymptomatic relief. So ultimately we are saving the limbs of the patient by saving him from the amputation. So what exactly this Hawk One catheter look like? You can see here it is the almost 300 plus centimeter catheter which has this, the distal end, the hub, the proximal end, the hub. It has this push and pull button. Then this proximal end, you can see the tip. Tip has the cutter. The cutter we called as a cutter blade, unlike we have like in the rotational atherectomy. And you can see this square box here exactly how this cutter look like. The first image is the off. When the system is off, it looks like a straight, but when you are in artery and you on it, so the cutter get deflated and you can take a directional toward the shaving of the artery. Now there is a two type of length. We all know that like in rota also we have the working length and the effective length. So working length is the total length is we have into the total vasoculture, and effective length the area you have the particular to take out that shaved plaque. So what exactly the Hawk One will help you? It will not take care of the normal lesion, but it will take more severely calcium lesions also. It is a simplified device. You don't require any capital equipment or anything. You just have to have this catheter with you, and you can take the the directional atherectomy in your peripheral disease patient. It is very fast for cleaning purpose also. Now, what are the innovation we have done when it comes to the shaving this calcium from this peripheral artery disease patients? So first is the increase in rotational speed. Previously, we have the Turbo Hawk. Most of the senior colleague over here, they know that they used to be Turbo Hawk was there. We have made 3 innovation in Turbo Hawk. Now it become Hawk One. So first innovation rotational speed. It is now 12,000 RPM. In Turbo Hawk, it used to be like 8,000 RPM. Second one is a drive shaft. The drive shaft which gives the electrical signal and the force to the distal end. We have also have innovation that one, and cutter blade design. We'll see this all 3 innovation one by one. So the robust drive shaft, which exactly the 4-level stainless steel shaft, which has given more force to the cutter driver to have the more cutting power. The blade design is a 4 counter blade we have used in the Hawk One, unlike with they were the only 2 with the Turbo Hawk. So you have the severe calcification cutting very easily. And another important technology, we have used a micro efficient technology. Whatever the material or debris you collect through the cutting, that that can be collected without losing any emboli or losing any debris. Only the fluid can go out of this nose cone or the micro efficient compression technology. Now, when it comes to the technologies like the most important part is fluoro. So how exactly fluoro should look like? So you can see easily all the cutter. In the left side image, you can see the cutter window, then the total nose cone, or I would say the tip where the debris get collected. You can easily see on the fluoro, and you can even assist your peripheral interventionist easily that where exactly the cutter and the debris is look like. Yes, so we have, as I told you, the nose cone technology, like the debris where we are getting collected is, it has a shape like a nose cone, and the most important that it increases the deliverability, trackability, and the predictability. The crossing profile of this Hawk 1 system is 2.2 mm. So this is just the comparison between the the Turbo Hawk and Hawk 1. We have reduced the cutter height and cutter length depth, because we know that the more shaving will cause the more damage to the artery. So we have reduced the cutter height as well as the cutter depth when it comes to the Hawk 1. So what is the role of the technologies? Generally, we have seen that in multiple cases the technologies assist the doctor to take a multiple check shoot and have the multiple check shoot at every pass. So we generally recommended 4 pass for the Hawk 1, like the anterior, posterior, left lateral, right lateral, so that you will have 4 passage. And once for all 4 passage, we ask technologies to take a shoot at each pass. So when you order Hawk 1 to the Medtronic guy, you should remember this 4 model we are available with. We are 6 French compatible also. We are 7 French compatible also. When it comes to 6 French, we have the 2 model, that is M and S. When we come say to 7 French compatible, we have LS and LX. The difference between all these 4 model, you can see the extreme right, that is vessel diameter. Which vessel diameter you are treating, according to you can order the different model. Now, what is the goal of the doctor? You can assist him, like a doctor want to have the maximum lumen gain, or he want to just have the channel. According to you also can select the all these 4 model. Generally, we recommend that if you want to have the maximum lumen gain, that means you must have the maximum passage. We recommend you should have the 7 French with LS and LX. But you just want to have the channel and you want to go for the DCB. Post that, you can go for the 6 French. That is the M or LS. So it is totally in the operator choice whether he want a maximum lumen gain or he want just a channel out of the Hawk 1. So again, this is just a comparison between M and S. Like depending on the vessel, you can decide. The Medtronic rep is always there inside the cath lab. He will assist you like which which model should be selected. What is the crossing profile of that model? So you just have to rest assured which model should be selected in that category. Just to summarize, what is the advantage of the Hawk 1? Like it is not capital equipment, it is just a simple catheter. When it comes to the cleaning, it is very simple loading and cleaning procedure. It has improved torquability because of the sharp design, enhanced the visualization because of all the cutter driver and cutter has been visualized. And the actual improved the cutter actualization, that is the shorten the shaft with the geometry. This is just the summary of the how Hawk 1 is all about. But of course, you will ask me, Rakesh, what is the proof of this? Is there any proof that Hawk 1 is better than the stent or the other peripheral devices? So we have the reality trial. In this trial, we have compared the directional atherectomy, that is Hawk 1, along with DCB, while debulking the severely calcified femoral artery. And we have taken the primary endpoint like the primary patency and freedom from the CDT-LR. Principal investigator was Dr. Krishna Rao, Raucha Singh and Brian DeBroge, and the Viva physicians. And design was like we have selected a 102 subject across the 14 sites from the US and Germany. It was prospective, it's still running, non-random single arm study. And all parameters of angiographic were adjourned. So what are the complexity we have selected? We have diabetic mellitus, 84% out of this 102 was diabetic patient. Prior periphery, PAD was there with 74% of patient. History of coronary artery disease was also with that patient. And most importantly, bilateral calcium, the bilateral calcium is very hardly to treat. As per the PACS, nomination, we have selected the, the most, the hardest calcium, that is the 3 and 4, that is around 86% of the PSA's combination were 86% and 67% were more than 5 centimeter. Average length was around 18 centimeter, and CTO almost 40% of the total population was CTO. And you will get surprised and honored to get shocked about the result. So, the freedom from the CD-TLR was 92% at the end of 1 year, and the primary patency was 76% with the artery. And guess what? Like the bailout strategy was used only in 8% of the patient. Bailout stent strategy were used in only 8% of the patient. So this is what the reality of the HOC1 plus Admiral Extreme DCB balloon was used. So this is one of the case we have done. You can see ECPA was totally occluded and the post HOC1 and DCB full flow at the and the other arteries also. This is another case. Complete block of flow. We did the HOC1 and DCB. You can easily see the collateral and the SFN fulling completely. The third case, same, full occluded. You can see the calcium at the circumficial and the nodules also. We have done the HOC1 followed by the DCP, and you can see the result. This is how the plaque, we generally take the photos of the all plaque when we remove from the directional atherectomy. You can easily see this is a soft plaque where it is a hard plaque and all that. These are the another plaque images. I'll just show you the animation video how exactly the HOC1 is done. It is a non-audio video. So the peripheral artery, the plaque, it is off mode. Now it is in on mode. It gets deflated. So it's shaving the, let's consider left lateral. And then get stopped, come back. It's pushing the all debris into the nose cone. Then you change your direction. Maybe right lateral, another passage. Then it's pushing into the nose cone. Nose cone is the system where we're collecting all debris. Posterior we are going. And we got the maximum lumen gain. So it was a previous image. Post the HOC1, you can get the image like this. That's all about me. Thank you. Sincere thanks from Medtronic. Any questions?
What is the cost?
Yeah, so like the previously it was very high costing, but now we are selecting patient to patient basis. But for HOC1 device the costing is around 90,000 to 1 lakh now. So if you use 2 Supera instead of Supera, you can have 1 HOC1.
Rapid exchange system.
Yes, it is rapid exchange, sir. 014 compatible.
What is the tip length approximately? From where a wire comes out, what is the distance?
Yeah, it is a 25 centimeters. 25 centimeter.
25?
Yes. Yeah, total centimeter. Turbo Hawk. Yeah, it's the same, sir. It's total same. Only that we have made the advancement. Yeah, so sir, yeah, when the operator does the HOC1, the atherectomy, the voice of the device gets changed when you collect the debris.
Yes.
Like in rota also, I think the voice gets changed the same way. Yeah. So voice gets changed. If the more debris is there, so you will find no voice at all. and then you have to take out. But that's why we recommend all technologists to have the after every passage one picture and one pull out, and just clean it and take it again. Another what we have seen, sir, in previous version, they were the detachable battery. So in India we have seen the multiple usage, but the result was not up to the mark, because in second or third setting that device not working, and we got the negative feedback, this is not no use. That is why we had the complete battery. Now you can't remove the battery in one setting. You have to use the hook one to that patient. Reusability is, we have avoided, but just to have the good result.
So that was the reason when it was recalled back.
Yes.
So that was the factory system.
No, I didn't know about the recall things, but from India we came to know that the second and third setting they didn't used to have the good passage and all that, because the battery life
The blade used to spoil, na blade.
Yes. BTK also. Yes, sir. You can have 16 passage in one cut on one hook one, new hook one. 16 package you can have.
So what is the blade length for SFA and for TBA?
Same. It is same.
It is only for HTLS and HT.
Yeah. Yeah. Yes. So, sir, yes. So here I will, yes. So when, as sir, Senthil sir was asking for the BTK. So BTK you can easily guess, BTK comes around 2 to 4. So we have to use S. So,
about LX and LX?
Yeah. So very good question. What about LS and LX? Both are same. When I say LX, sir, when you have the more debris, the nose cone where you are collecting debris, it is you can see up here only 6.6 centimeter of nose cone, that is tip, with the LS. When you say LX, you have 9.6 centimeter of nose cone, that is the tip. So you have multiple. Yeah. Yes.
200 centimeter lesions and all, we take the 9.
No, it's not like that, sir. Even the long lesions, calcific lesion, mid calcium, any lesion you can take it. The only the contraindication is the coronary, carotid, iliac, and renal one.
It is not only for eccentric, na? It is for circular.
Both. Yeah, circumficial. We have case in for the.
It is eccentric, 180 degree.
No. Eccentric. For the eccentric, it is not recommended. It is for the circumficial mostly.
So it rotates again?
No, it doesn't rotate, sir. We have to change the direction. Yes.
Manually change.
I don't know, sir. The medical, maybe we have the bifurcation there.
Bifurcation.
Maybe because of that, the iliac artery is contraindicated. Because bifurcation, you have seen that it get deflated. The tip get deflated, and to passing to that bifurcation quite be very difficult. Yes, torch. Yes.
It cuts 180 degree, no?
Yes.
Yes, sir. It cuts 180 degree. So
Sir, I can't hear you.
This device, the device cuts 180 degree, no?
Device start at 180 degree.
Cuts the calcium.
Yeah. It cuts at
180 degree, no?
It is a directional atherectomy. For example, this is the artery. You want to cut this type. So no. It is one parallel. It cuts the parallel, sir.
Parallel.
It don't cut the left lateral also and right lateral at the same time. It just cut the.
So you have to rotate.
Yeah.
Rotate and
where you take the blade, it will cut that only.
So there is any marker jo rotate?
Yes. I'll show you, sir. Here is the mark. I'll show you if you have time. I'll show you the video again. Yeah, there you go.
Show the video. Fluoroscopy we had 2D view, no?
See. See, in fluoro, I got the question for technologies, fluoro is more concerned than video. Yeah, but just see the first image. This C shape. Can you see this C shape?
Yes.
This C shape is a blade.
Okay.
So suppose you want to cut this side, you get direction to C shape up to this side.
In the same view.
In the same view. If you want to have the right side, rotate it, and you can rotate in vasoculture also. You just take out the debris and rotate it, and you can get that side. For anterior, you can again have to get the C shape toward you, and for posterior you have to get the C shape to the posterior side.
Okay, anterior, posterior. Okay, thank you.
Yeah, exactly, 90 degree. Yeah, in degree ways we can say 90 degree. Yes. No, generally we don't recommend because suppose at the left lateral you have the more calcium and the device get full, there is a high chance that it will get little bit disturbed or the emboli. So we always request for one passage, take out the your device, clean it. Cleaning just take 2 minutes. Yeah.
You can use for both the legs, no?
16 passes you can do. 16 passes. 16 passes. 8 here.
Yes.
10 here, 8 here.
Okay, you are saying that one device can use here. You can use 16 passes, sir. Yeah, 16 passes you can do.
Nobody does it bilaterally.
My-
Is there any, where is the upper limit? Yeah, 16 only.
No, 16 like we have got the case, after the 16 passage, the device battery got compromised. See, if you want to have sharp shaving, the battery should be competent enough. My only submission to all the technologists over here, just request your peripheral intervention to at least do a Hawkone cases at least once, because our man will be there to assist them, and then you will see the miracle with that patient. Like, yes.
What is the complication?
A complication is the when there is a vulnerable plaque, and that is the doctor, the soft plaque, where it is high chance that it will emboli. So we recommend spider to be used. We recommend spider to be used when there is a vulnerable plaque, or whenever doctor doing.
It is very good for CTOs, if wire passes.
Yes. Yes. So rota, we can call it a rota of the peripheral SFAT.
You will find at only small segment.
Very true. So we.
Thrombode completely occluded, will be using.
Yes. Which one, sir?
Yes.
Yes, obviously. Acute thrombosis is like we can easily cross through the wire also. Actually, we generally recommend for the severe calcific lesion, mid-severe calcific lesion, distorted lesion, you can use this device.
Do we require to use a drug-eluting balloon also? Rakesh,
Sir.
do we require to use drug-eluting balloon after this?
Yeah, pose this, very good question asked by Anil sir. Pose this atherectomy, shall we do balloon or no balloon? So we always recommend go for a DCB. We always recommend, because we have already cut the endothelium and we need a good healing. So we require drug. So we always ask, the doctor to use a Hawkone plus DCB, and this reality trial also based on that Hawkone plus DCB. And then DCB, yeah. So we got almost, 92% CDTLR free patient out of that reality trial. Exactly, sir. Because after 6 months, patient always come back. Now, what is the problem? I'll share, in this group. What is the problem? Doctor is not, that much, taking this therapy so aggressively. So we have started doing the observership in LTMG now. The first observership across, first time in India we have done. No, I'm not saying stop using Supera. It is doctor choice. I'm just saying that therapy is not that much aggressively taken in the way.
See, one thing is right. For joints and all that, Supera is not, still it is not good. For suppose knee position, this is a good option.
Sir, even the full more, the big lesion, there, you used to have 2-3
because
stages.
Because joints and all that stents are not recommended.
Very true. But in peripheral, we always have to avoid the stenting, because we know that the patient will going to come back, unlike with coronary. Patient immediately nahi aata, but peripheral mein 6 mahine mein aa hi tha return with some symptoms.
It depends.
Yeah.
See, everything still peripheral work, still people are learning. It is not up to the mark.
Very true, sir.
All the doctors are still learning. Very few are there who are really trained.
Yeah.
Otherwise, everybody is learning.
So we have started, sir, observership, especially for those doctors who want to take this therapy to their center. We gather all these 4-5 people, and there is one operator in Mumbai. He has done almost more than 30 cases. So then we take them to them across India, and we are started doing this observership for them.
Nice.
Thank you so much.
Yes, thank you. So, by that, we are coming to the end of the session. That was a pretty long session, actually.
Interactive.
Yes, interactive session.
But it was nice, no?
Yes, it was nice, but I didn't understand anything. Must be interesting for you.
Nice.
Yes, thank you. And few hours ago, I was just telling, I could see so many excited faces, but literally when I look at you, all of you now, I could see only exhausted faces. Most of you all look so tired. So anyway, have a happy weekend. Enjoy your stay in our God's own country. That's it. Me, Mulcha Parekattal, signing off. Have a great day. Thank you.
Thank you.